trabs alone, wait it out, let the IOP stabilize, and then I do the glaucoma, the cataract part of it. Rest of the patients, I do the phaco trap. Trap versus tube in advanced glaucoma, I think the topic has been very well covered. Those patients that deserve low pressures, if you are a good trabeculectomy surgeon, there's nothing like doing a good trap. A good trap, a very well trap, is a pleasure to watch. So if you know how to do your trabeculectomy, then you know how to, that will be my first choice. There are some situations like neovascular glaucoma, uveitic glaucomas, where a tube obviously is the choice, or if the conjunctiva is completely scarred down, so the trap is not going to be of any use. How about some unique cases that I was talking about? Here is a patient with malignant glaucoma in a nanophthalmic eye. So problem with nanophthalmic eye, if for malignant glaucoma, you have to do a pars plana vitrectomy, but you don't know where the pars plana is, right? So do a trabeculectomy and do the PI. Through the PI, you're going to go in, introduce your vitrectomy, and complete your vitrectomy, and in literally 10 minutes, the entire surgery is done. And I've never touched the pars plana. For a glaucoma surgeon, this is beautiful. I don't want to mess with where the pars plana is or induce a detached retina in this kind of eyes. I've done this for a number of years, works perfectly, this technique. Almost 100% of the times, you don't need to go with a retina surgeon for a pars plana vitrectomy in these cases. There you go. I mean, it's a simple enough procedure that you can take into your practice for chronic angle closure glaucomas and nanophthalmic eyes to resolve the malignant stage. How about this patient who presents to you with acute angle closure glaucoma? Why do we need to wait for the patient's eye pressure to drop down before you intervene? So if for the last 20 years, when a patient presents to my practice with acute angle closure glaucoma, probably they would have already seen 2-3 ophthalmologists in the community. They come to me, they go with a betadine prep and lidocaine gel, lid speculum, they sit at the slit lamp, 30-gauge needle into the anterior chamber. Here is a close-up shot. Within 2 seconds, all it takes is to drain out 1 drop or 2 drops of aqueous, cornea clears up, the pain is gone, and then the patient is super happy. Then take the patient to the laser room. I use organ laser 360 degrees to perform arthroplasty, and a week later, I take the cataract out. How about the fellow eye? I don't wait. I don't play this game of wait and watch for the fellow eye. I tell the patient, you're at high risk, take the cataract out before he or she develops another attack of glaucoma, right? So if prophylaxis is what medicine is all about, why are we making this patient
1 international unit per ml, what we get the 40 Actrabid. We can keep it in the fridge and prepare it weekly, fresh. Nowadays I tell the patient if they are intelligent to prepare themselves, they stay far off. But one day accidentally my math skills are poor, so I put 2.5 ml in 7.5 ml of lubricant, and that seemed to work, though the earlier thing did not work. So higher doses up to 50 international unit per ml also are said to work, and they have been used in vitreoretinal surgeries with poor epithelial health. It takes time, 3 to 4 weeks time.
One of the companies is actually making it commercially now.
Okay, that's good.
It'll make it easier for us. Yeah.
Thank you. So it is. It helps in proliferation of the epithelium. It is a growth. It acts like a growth factor and also prevents apoptosis of the epithelial cells.
Ideally, we need nerve growth factor, but it's too expensive and it's not available in India. So this is a substitute.
So our next speaker is Dr. Varun Malhotra. So he is going to speak about sterile corneal men.
Thank you very much, Dr. Swapnali, and good morning to everybody. So my talk is on sterile corneal males secondary to a case of rheumatoid arthritis. I need one pointer also, please. I need one pointer, laser pointer. So this was a 72-year-old female patient and she was complaining of blurring of vision for the past 3 weeks, which was gradual and worsening progressively. She did give a history of rheumatoid arthritis for the past 10 years, on homeopathy treatment for the first 7 years, and not on any treatment for the last 3 years. So it was important to note that she was not on any kind of immunosuppressive treatment at all. Her best corrected visual acuity in both eyes was counting fingers at 1 meter, and refraction showed a dull glow. The other things were normal, like head posture. Her ocular motility was full, free and painless. Her pupillary reaction was sluggish. She did have scanty mucus in the left eye. So as you can see here clinically, the right eye showed superficial corneal vascularization, and there was an epithelial defect with the central sterile melt, about 2 mm to 1 mm in dimensions. There were no corneal infiltrates here, no hypopyon in the AC at all. The left eye did show a small corneal melt right at about so you can see a small corneal melt here with iris prolapsing and plugging it completely. There was again no KPs, there were no corneal infiltrates at all here, and the patient was Siedel's negative in this eye. The fundus was very hazily seen due to a dense lens opacity. The lens was cataractous. So a provisional diagnosis of bilateral sterile corneal melt was made with perforation in the left eye, secondary to rheumatoid arthritis. So we started the patient on lubricants in the right eye, and antibiotic and homide eye drops. And in the left eye, I gave them lacrygel eye ointment as well. A rigid shield was put in the left eye before we planned for a corneal patch graft. Oral doxycycline was started, and also oral steroids. We immediately sent the patient for a detailed collagen vascular disease workup, and I also asked them to see a rheumatologist friend of mine with whom work very closely for managing all the patients of Sjogren syndrome. So the next day I did a cyanoacrylate glue plus BCL for the right eye, since there was there was fair amount of corneal thinning, but there was no perforation, and we just decided to seal the impending perforation. In the left eye, I did a corneal patch graft under local anesthesia. By the time the blood investigations showed that the ESR was 135, which was grossly elevated above the reference level, CRP elevated, and RA factor was 108. In the meantime, my rheumatologist had started her on oral methotrexate, 15 milligram weekly. On first post-op day, glue BCL was in place in the right eye, and in the left eye, the patch graft was well anchored, BCL was in situ, and AC was well formed. So the patient ophthalmologically looked quite stable. And these are the post-op photos where there was a glue BCL here and a patch graft which was sealing the corneal melt. I saw the patient on first week post-op where she did complain of a flare-up of pain in the left leg. She was unable to move and was being treated by a rheumatologist. She had also seen an orthopedician in the meantime. But as far as the eyes were concerned, they were stable. And then I had called the patient next week again. But then 3 weeks elapsed and the patient did not come back. So I asked my secretary to call up, and because I was quite keen to know what is happening in this case. And this is what I came to know. The patient had probably left all of us. She did have a cardiorespiratory arrest a week back. So the point I want to make here with this case is that the sterile corneal melts are crescent shaped. These are inflammatory lesions. They generally involve perilimbal area. They are always associated with an epithelial defect. 50% of all the non-infectious PUKs have associated collagen vascular disorder. The most common causes are rheumatoid arthritis, Wegener's, relapsing polychondritis, and SLE in descending order. There's a very high mortality rate associated in cases of PUK in the setting of a systemic disease, and which is why it is very important that when you see any kind of sterile corneal melts with an underlying collagen vascular disorder, to always involve a rheumatologist in your treatment as early as possible and start the patient on immediate immunosuppression. And ESR more than 100 is a definite warning sign, it's a red flag. Rheumatoid arthritis is the most common cause of sterile corneal melts. It is generally bilateral in more than 1/3 cases. Importantly, any corneal involvement is a late phenomenon which generally occurs 12 years after the rheumatoid arthritis has set in. The corneal melts in a case of RA indicates the transformation into a systemic vasculitic phase, and this is a life-threatening condition. It does have a poor visual prognosis and a very high associated mortality. Wegener's has very high risk of ocular involvement, and generally you see a PUK in about 6 months' time, but then the mortality is not very high because you tend to intervene much earlier. Relapsing polychondritis again is a fairly mild ocular involvement wherein episcleritis and scleritis are common. Prevalence of MELS is less than 10%. Pathogenesis is again, overexpression of MMP2 and, wherein these inflammatory leukocytes and cytokines involve themselves and thereby cause a corneal melt. You immediately have to start the patient. So as soon as you see a sterile corneal melt wherein you have ruled out any infection, immediately start the patient on systemic corticosteroids and immunosuppressives. There is no role of topical steroids because it may actually increase the chances of a further corneal melt. The cytotoxic agent of choice in this case is methotrexate. A newer drug being evaluated now is mycophenolate mofetil, MMF. Well, Wegener's responds very well to the immunosuppressives, much faster, also because we intervene much earlier, and the response to the therapy is monitored by Cianca. Please start aggressive lubrication to prevent symptoms of dry eye. Sometimes we can, if these lesions are near to the limbus, we can also do a conjunctival resection. Penetrating keratoplasty may be required wherein there is a complete corneal perforation more than about 2 millimeters in size. For corneal melts and perfs less than 2 mm, you can still do a patch graft. Lamellar grafts or a keratolimbal grafts may be needed in larger perilimbal crescentric melts, and BCL and tissue adhesives can be used initially to preserve corneal integrity. The number of full thickness grafts being performed for melt remains very low because these melts are smaller in size, but whenever they are performed, they have a very high likelihood of melting again and requiring a regraft. So the point which I want to make here, and the important takeaway messages are that the diagnosis of sterile corneal melt in a setting of systemic disease should be considered an emergency, and management has to be done by a rheumatologist and immediate cytotoxic therapy to be started. Thank you.
That's a wonderful presentation, and I think this is to emphasize that any stromal melts in a patient with rheumatoid arthritis or any other immunosuppressive autoimmune diseases is a medical emergency. It's not besides being an ocular emergency, you have to take the help of a physician because the 5-year mortality rate is nearly 80 to 90%. So you have to look at life and also treat the eyes simultaneously. Please be aware of this situation and treat appropriately. Thank you.
Thank you, sir.
If I can add something, in such cases, since there is a very high risk of even the corneal graft melts, sometimes if it's a small perforation, we can actually get away doing with a tenon patch graft.
Tenonplasty as well, yes.
Because you need to give preoperative IVMP for that patient, and generally these patients are already chronically neglected rheumatoid arthritis patients, and sometimes they are not suitable. So in an emergency, and suppose if you are in a situation where you cannot get tissues, tenon patch graft would be another option also.
Correct.
Just one word of warning, sometimes infectious keratitis can also present with a peripheral ulceration which can very much mimic like a sterile corneal melt. We know even fungal infections can come like that, viral can present. So always keep infection at the back of your mind and rule it out.
Rule it out.
Because steroids is going to make it worse. So we'll move on to the next speaker, who is also the convener of this session, Dr. Swapnali. She is a senior cornea specialist in Hyderabad, and she is heading the ophthalmology services at AIG Hospital. And she is going to tell us about Revive Real Tears in Dry Eyes.
Good morning, everyone. This is a sponsored talk by AbbVie, and I am very thankful to the TOSCON committee and Dr. Rishi for giving me this chance. So what is the definition of dry eye? So we know the definition is becoming longer over the years. So there is now considered to be a multifactorial causation. And among the other things, inflammation of the ocular surface is one component of dry eyes. So this is the ethiopathogenic classification where we have aqueous deficient and evaporative dry eye. So each of them have their own causes. What are the key mechanisms of dry eye? So it's a vicious cycle. There is tear film instability, hyperosmolarity. This causes cell damage and apoptosis, causes inflammation on the surface, leads to more surface damage, and the cycle goes on. And along with that, if there is any lid problems, meibomian gland dysfunction, this adds to the tear film instability. These are the causes of all the different factors which can cause dry eye in a patient, and the cycle goes on and on. So in this we notice that inflammation plays a major role for causing dry eye disease. What are the consequences? So inflammation causes tissue destruction, neurosecretory block, and then chronic neural damage happens. This leads to reduced reflex tear secretion, loss of sensory drive, decreased sensitivity, and then there are different kind of problems which happen on the surface. The cytokine activation causes apoptosis, loss of glandular structures, disruption of the nerve cell function. There is more production of adhesion molecules and neurosecretory block. One particular proteolytic enzyme called MMP9 plays a big role in dry eye disease because its increase causes a disruption of the corneal epithelial barrier function. This leads to corneal surface irregularity. So what we see here is a vicious cycle where there is a positive feedback loop of the inflammatory mediators. This causes further apoptosis, this causes more inflammation, and the cycle continues in a pattern. Now we have to break this. So how do we diagnose dry eye disease? I think most of us are already doing it in the OPD. We know the usual symptoms of stinging, dryness, grittiness, foreign body sensation, etc. Presence of air conditioners, wind conditions, and prolonged reading, prolonged TV watching, gadget use can increase it. So initially the inflammation may not be evident or overlooked. So we need a thorough medical history and an ocular symptoms evaluation. Then we determine the visual function and do the regular checkup of the eye, including corneal transparency, lid margins, and the eye from the front to the back. So this is the order of the diagnostic tests which are done. So we have ocular surface disease index, which can be given to the patient in the dry eye clinic when they are waiting for the checkup to be done. Then we examine the face, do the slit lamp examination, the tear breakup time, ocular surface staining, shimmer, and sometimes the lab test. So these are the changes we usually see on the face and the ocular adnexa along the lids. The tear breakup time can be measured both invasive and non-invasive manner. I prefer the non-invasive. So in invasive, we have to instill the fluorescein onto the bulbar conjunctiva. Now within 10 to 30 minutes, the patient should look straight without blinking, and we record the time between the last blink and the appearance of the dark spot on the cornea. Values less than 5 strongly suggest dry eye disease. Then we go for the different stains, lissamine green, fluorescein, and rose bengal to identify the areas of corneal and conjunctival damage. Schimmer's test is very commonly done. It has its fallacies, but it is a very easy test to do in the OPD in the right condition with low humidity, low light, and the AC should be switched off. So it can be performed with or without anesthesia. The only thing we should remember is that we have to wait for 5 minutes before we find out the actual value. The other diagnostic procedures are mainly laboratory initiated. So there are tests for the ocular surface, the tear film, and the serum, which are not regularly done. The standard therapies are, of course, lifestyle modification and patient education, artificial tears, which are the first line of treatment, and patients with moderate to severe dry eye disease need some anti-inflammatory therapy to control the ocular inflammation. So these are the summaries of the anti-inflammatory therapies available. There are oral medications and topical medications, out of which the oral medications can cause problems with the systemic condition. And then corticosteroids and other tetracyclines and all cannot be used for long because they have long-term side effects. So cyclosporine A is a good option. This was approved by FDA in 2003, and it has a good mode of action against T cell activation, leukocyte migration, inflammatory cytokine mediator inhibition, and protection against apoptosis. So it can be used both for Sjogren's and patients who do not do well with artificial tears. So the good part is that the active ingredient itself is good, and in Restasis formulation, the inactive ingredients also help in stabilizing the eye surface. So there are multiple tests. The this one, studies which have shown the improvements of signs and symptoms at all severity levels. This includes increase in the TBUT time, decrease in the fluorescent staining, and then there has been reduction in the use of ancillary drugs when cyclosporin A has been added to the treatment. So when we compare 0.5% versus 0.1% cyclosporin, we do not find much of a difference if the dose is higher, as this study shows. And there is reduced need for concomitant use of artificial tears when cyclosporin A is combined with artificial tears. The 2 years use, so many patients ask me how long do we have to use cyclosporin A. So this study shows that up till 2 years, there was increase in the tear production. The Schimmel's test score was better, and when artificial tears was combined with Restasis, again the tear production increased. So the blood concentration has never shown any higher levels with the use of topical cyclosporin, which was proven in this study. Patient compliance, again, it's a twice daily dosing, and we usually give up till a period of 4 to 6 months. And duration of treatment is long, so there is a tendency of loss of compliance. So patient education is very, very important. So we see here that with the longer usage, the values have significantly improved for all dry eye disease patients. Patient education is a trial which was done to see how much the compliance matters, and it was seen that if the patient is educated initially, they do respond to the compliance level, and 80% of patients showed clinical improvement. So in summary, inflammation is one of the key mechanisms of dry eye disease, so artificial tears are not sufficient, and the stimulation or with the positive feedback loop has to be kept in mind. Proper history, systemic evaluation, and slit lamp examination with the ocular surface staining has to be mandatorily done in these patients. The therapy for treating inflammation includes the artificial tears, and sometimes we need autologous serum also in very bad cases, and cyclosporin A is available. So cyclosporin A is effective at reducing the signs and symptoms of dry eye disease with no serious adverse events. Most important is patient compliance, because the treatment takes at least 4 weeks to start working. So patients have to be educated that the treatment has to be done at least for the period till which the physician tells the patient to do. Thank you very much.
That was a comprehensive talk, Swapnali. It was nice. One thing, just for a take-home message, besides the lubricants which we all use, do you find there's any difference between carboxymethyl cellulose versus hyaluronic acid? What's your preferred drug of choice?
So in mild dry eyes, I usually start with CMC, and then patients with moderate who have used CMC before, I then convert to sodium hyaluronate. But patients with severe dry eye disease, I see most of the time they are not happy with CMC. Okay. So they need something with more viscosity and which stays longer. So since I work in a multi-speciality, I get most patients with moderate to severe dry eye disease. So among the panelists, anyone has any other opinion on this?
And also about cyclosporin, which is your preferred choice, Restasis or Sequa? I mean, these are the two things which are in the market.
So Restasis, yeah, like so Restasis is 0.05, Sequa is 0.9.
Yeah.
So we have recently started using Sequa. Restasis is time tested. So the only issue sometimes is the cost factor.
Yes.
Yes, so Sequa has a long way to go. So maybe by the next meeting we will be able to tell which works better. Do you have any experience on that, sir?
Yeah, I have tried both. I really, it's only anecdotal. Both are more or less similar. And how about use of something like cyclosporin drops, like cycloimmune or hydroize?
So yes, the generic medicines also work well. We have sometimes in our hospital we have to see the patient profile and give them generic medications, and they do work well.
Yeah,
yes.
They're equally good and they're less expensive. Everybody can't afford
Restasis. True.
And I think another important thing is when we see patients with dry eye symptoms, we start treating them on medications. But if a patient keeps coming back and is significantly disturbed, especially if it's a younger patient, that's when we should immediately investigate. Even our cataract surgery patients, we might just do a Shermer's and leave it, but there's some symptoms which are so significant. When you investigate, you realize that there are certain collagen disorders which are underlying, which were missed.
So the thorough history taking, which is like more time consuming, is very important in patients with dry eye disease because it is so multifactorial.
And I think tear breakup time is the underused diagnostic
Yes.
test in our OPD. Like we have computer vision syndrome cases, lot of patients coming back. They don't give specific symptoms of dry eyes, but they are heaviness and eyes, uncomfortable. So in those cases, suppose you do TBUT, you can definitely diagnose that.
Yes.
Whether
And
they
for
have-
Schirmer's also,
Schirmer's
if you have a doubt of what your technician or optometrist has done, it is always preferable to do the Schirmer's by ourselves.
Yeah, Nitesh, please go ahead.
Yes.
Yeah, thank you.
At the outset, I would like to thank Dr. Swapnali and HOA for the invite. So coming to my challenging case. So I had a 38-year-old male who came to me with complaint of blurred vision in both eyes since the past 4 years. He had history of undergoing LASIK elsewhere in 2000, and you can see the best corrected vision was 6/60 and in the right eye and 6/12 parts in the left eye. And these are the topography scans. You can see that the patient basically has ectasia in both eyes. So basically it's a case of post-LASIK ectasia, right eye more than the left eye. And since the patient was not very comfortable with contact lenses, we went ahead and planned DALC, and the patient wanted to go for the femtosecond laser assisted DALC as well. So yeah, coming to the video, basically we do a kind of mushroom cut pattern in these cases. The anterior diameter is bigger than the posterior diameter in these cases. And as you can see, after completion of DALC, I noticed a big perforation of close to 3 clock hours. So what I did here is I closed the wound with interrupted 10 nylon sutures, and since I had a lamellar cut at close to 90% depth, so I had an idea of how deep the dissection could be done. So from one side I went ahead and sutured the wound, and from the opposite end, because it was a deep cut, I used a manual dissection. This is close to 90% depth. So I am doing a basically manual dissection technique of DALC, and you can see that in between the AC was flat, but these patients do have a very good endothelium, so that should not be a big concern for us. So I went ahead and removed the anterior cap of the recipient bed, and then the cap, which was also cut with femtosecond laser, was again sutured. You can see at this point as well the AC is flat. So I went ahead and put the 4 cardinal sutures, and then after I used air to form the chamber. As you can see, once the 4 cardinal sutures are placed, the AC tends to form pretty well, and I generally use intermittent 10 nylon sutures. So it looks good. I used 16 10 intermittent nylon sutures, and this is the end of the procedure. You can see the AC is well formed, and this is how the patient looked post-op day 1. So post-op day 1, the patient did have a raised pressure of close to 50 millimeters of mercury, and the air bubble was filled with AC. So we made a diagnosis of Urich-Zavalia syndrome, and the patient was given IV mannitol with prednisolone and Combigan as well. And at 1 month post-op, the patient did have a good visual acuity of 6/24 parts. He had a kind of central haze for the decreased vision. The IOP was well controlled with Mysop drops. There was mild graft edema as well, but the pupil was very much dilated with lot of pigment dispersion on the lens. 6 months follow-up, the patient had a good vision of 6/18 with correction. The pupil was still very much dilated with atrophic patches because of the Urich-Zavalia syndrome, and the patient did have a central posterior subcapsular cataract as well. So this is a follow-up of the patient. You can see that the cornea looks okay with some amount of cylinder, and the last follow-up, the patient had a vision of 6/12 parts with a site of central PSC. And this is when the patient came back to us with complaint of blurred vision again, with drop in visual acuity. The vision had dropped to 6/60, and you can see all the sutures are out, and the graft is well opposed. The cornea is very much clear now, but the pupil is dilated with lot of atrophic patches. So the plan was to do a cataract with pupilloplasty as well. So as you can see in this photo, you can see there is a central PSC. So we did a phaco with IOL, and the IOL power in this case was -2 diopters. The axial length was 28.79, and post-operatively the patient did had a good visual recovery of 6/12, and the glare also was very much reduced in this case. This is how the clinical picture of the patient looked at the final follow-up. Thank you.
Yeah, well done.
Thank you, sir.
After so much effort.
I think because you continued with the DALC,
Yeah.
it was more forgiving. Had you
Yeah.
converted to a full PKP,
PK,
it
yeah.
would have been difficult.
Because generally these patients have a good endothelium, so I think that's why I went ahead and did it. Yeah, I think when you go back to pre-op planning, I could have done better in this case. Basically, this was a decentered cone. As you can, when you go back and look at the topography maps, this was a decentered cone. I think I should have marked the cornea, at least the cone part, before going ahead and docking the time. Basically, what I went ahead was mark the center of the cornea and went and docked the patient. I think in hindsight, I should have marked the cone and then went ahead and docked the patient.
Another thing, Nidesh, I feel that looking back, femto itself was not a good decision because we can't really, it takes a uniform cut.
Yes.
Whereas we don't know how much thickness and everything is there. It's better to go manually and then feel it and then slowly dissect it because that's probably...
Yeah, I think in this case the cone was slightly bigger in size. In central smaller cones, I think you can go ahead and do femtodalc as well.
Yeah, but I think we'll have to make sure that the thickness is less.
Yes, correct.
We
That
don't
can
really
be manipulated on the parameters on the femto machine, sir.
Yes.
Yeah.
Madhukar, hi, you cannot escape me. So,
Cornea is important.
yes, cornea is important. I do a lot of cornea too. Couple of points, wonderfully done case. When the pressure spike happens following any cornea procedure, you don't need to give this IV mannitol and all of those things, and the fixed dilated pupil can. The reason why you get that is acute pressure spike, just like in acute angle closure glaucoma, ischemia sets into the iris, and that's why you end up with this. Take a simple 30 gauge needle at the slit lamp. If you do a DSAC and the air bubble, just tap it, push the iris down, some of the air bubble is going to escape out, and your attack is over. All this high drama of IV mannitol, it just prolongs the agony for the patient and for you and everything else. Get used to doing that.
That's a good suggestion, sir. Yeah.
Wonderfully done case. And in terms of the previous cases that were presented, one option for both the neurotrophic ulcers that don't respond and also the sterile corneal melts, think about a very well done Gunderson flap. It's a lifesaver. It brings in the necessary blood vessels into that area. You put your patch graft in, amniotic membrane on top of that, and bring in a small Gunderson flap into that ulcer area, seal it shut, and they do extremely well. Even if the patient disappears, I'm not worried about those patients. Obviously, they need to be followed up, like was correctly pointed out, but something that I thought I should bring to your attention. It doesn't cost you anything. You don't need to get tissue from elsewhere. It's the patient's own conjunctiva. Thank you.
No, thank you for highlighting this point. Gunderson's flap is a very underutilized thing, and in many cases it can be used, and it's cost effective, and it can be done anytime, anywhere.
And to Rishi's point, what if it is a fungal infection or something else? Even in that situation, a Gunderson flap is going to work. You bring in the blood vessels, it's going to heal that ulcer. It doesn't matter what the etiology of ulcer is, a Gunderson flap always works. So I should never say always, most times it does work.
Agreed. Thank you.
Our beautiful session today, and I'm really thankful to all the speakers and the panelists for taking part in this session. I now request our guest speakers to be felicitated by Madhukar Reddy sir. So first for Dr. Chitra. Dr. Vijay Lakshmi, Dr. Charuta, yes, Dr. Suchismita. To give the certificates. Over the podium to Dr. Nitesh next.
Moving on to our next session of Dr. Rangachari Clinical Challenges session, I invite Dr. Mohan Rajan sir. I said,
and this was the gonioscopic picture. And we dilated the patient and confirmed the normal disc. So this was how the post-op the patient was. The disc looked, the anterior chamber was deepened in both the eyes. And post LPI, we tapered the steroids, stopped the atropine, and continued the anti-glaucoma medications. And we asked the patient to come back after 1 week. At 1 week follow-up, before that the patient requested an urgent appointment within 3 days, and she had pain and blurred vision in her left eye. And on examination, the anterior chamber was shallow with a raised IOP with combigan in the left eye. So this was how shallow the AC had again become. This is post-PI and the hyalodotomy. But the right eye remained deep. So we could confirm a diagnosis of aqueous misdirection now due to the presence of the PI. Still the AC was shallow. And for management of the patient, we had to keep 3 things on mind: that there was recurrence after discontinuation of atropine, there was 360 degrees pass in the left eye, and the patient had very limited time as the patient wanted to fly abroad. So based on this, we planned left eye trabeculotomy with ostial iridozonular hyalodovitrectomy and a primary posterior capsulectomy. Patient was back on atropine, combigan to continue, and preoperatively we had given mannitol to the patient. So in IZHV, we introduced the vitrector, and through the zonules, through the ostium, the vitrector goes. We do a zonulectomy, anterior vitrectomy, and a posterior capsulotomy. Here you can see the video that through the ostium itself, we have removed, after the iridectomy, we introduce the vitrector, and we go do the anterior vitrectomy, and we turn the vitrector forward and also perform a posterior capsulectomy. So 1 week post-trab, the AC had deepened, and you can see a posterior capsulectomy in here. And post 1 week follow-up, the vision was 6.6 and 6, asymptomatic, IOP was 16, and the right eye was deeper but still shallower than the left eye. So this is how the post-op pictures looked, and preoperatively, just to recap, this is how shallow they were. So at 4 years also, patient maintained everything well without any anti-glaucoma medication. So the key message is carefully assess the anterior chamber depth preoperatively. Primary angle closure may be present in the absence of disc changes and may be missed. Biometric parameters on A-scat should raise a suspicion, and not all dilated primary angle closure attacks will have an acute attack. Therefore, a mere YAG PI would have been preventive and all other investigations avoidable. This could be potentially a case of litigation. Thank you.
Probably had you continued the patient with atropine,
Yes.
the third day attack could have been avoided.
Ma'am, the only issue we had was patient had come here as a referred patient, and she had only 10 days time in India. She had to travel back abroad. So if we had put her on atropine and sent her, follow-up would have been difficult.
No, why would it have been difficult? I mean, I would have not taken off, I wouldn't take off atropine easily.
No, atropine was taken off because the patient did not like atropine. It gave her blurred vision. So it had to be taken off. She was an avid reader and she was not being able to
What
read.
was,
That was
yeah,
the treatment at that time.
I know, but
She wouldn't have had the repeat episode which happened. No, if you discontinue atropine, you can have a recurrent attack. So you
Yeah.
to manage it definitively, you have to do surgery.
two-
Otherwise, you keep them
yeah.
on atropine lifelong.
Very nice
Like-
presentation. There's just two things I want to ask you. What was the systemic medication the patient was? Because we had reported a long time back, me and Sridhar Rao reported sulfonamide induced Bactrim DS producing this.
No.
Yeah.
Patient was not on
Any
drugs which are known offenders for ciliary effusion, ciliocoroidal effusion. In any case, UBM was done. To exclude that.
Yeah.
Also.
We have done just vitrectomy, anterior vitrectomy, and that is anterior hyalurectomy, that is vitrectomy pars plana we do, and then remove the posterior capsule as well, and without trabeclectomy. Why do you want to do trabeclectomy for this patient?
Just to follow, because sir, otherwise the pressures, we have to follow up if we do only a vitrectomy with a
Because
capsulectomy.
already you have done PI.
Yes.
But I just done an anterior vitrectomy, and because in some patients we have done just an anterior vitrectomy and posterior capsulectomy, and they have done well as
To
well.
be fair to him, he was not there when the patient was being followed up. Basically, patient had come for 2 cataract surgeries and landed up in trouble. Patient was not keen to continue any kind of medication long term. If we hadn't done a trabeculectomy, she would have had to be put on anti-glaucoma medications also. So therefore, the IZHV was done via the PI that was created at the time of TRAP. You will have noted we didn't do mitomycin C. It was not required.
Not required.
A plain trabeculectomy was done, and to this day, she's come back to me now 4 years later, and she's completely controlled, nice diffuse bleb, and AC quite deep, and no changes to the IOL position.
Do you advocate a routine PI for all hyperopic patients?
No. They have to undergo a gonioscopy. You have to assess whether they are at risk.
No. What I'm trying to say is when you're doing hyperopic cataract patients, very shallow chamber or more than 30-35 diopter or less than 21 millimeter of axial length, 21. Do you advocate PI for these patients?
Those will probably have occludable angles. So yes, of course. However, without gonioscopic evidence, it's a little bit dicey to do PIs for everybody. We are actually moving away from PIs. The recent EAGLE study has recommended cataract surgery first rather than PIs. But the consensus in India remains the same, PI first, in occludable angles. Not necessarily suspects.
I'm not talking about the PI preoperatively. I'm talking about surgical PI
At the time of
during
surgery?
cataract surgery.
Yes, you could do that.
Yes, that's what I said.
Definitely.
Yeah. No problem, sir.
Hey, great
Hitesh.
case, great presentation, by the way.
Thank you, sir.
I completely agree with
See, we're
stopping
running
the
again.
atropine. This is not something that you want to put any patient for lifelong. I don't recommend putting in atropine unless it is one thing that you cannot avoid for some of these malignant glaucoma cases. I think the challenge of stopping the atropine and recurring attack proves your point, and what was done was very appropriate. And I recommend doing the trabeculectomy, via trabeculectomy, doing the PI, especially in an non-ophthalmic eye, simply because you don't know which one of them, in your particular patients, it may have resolved the attack. But in our world, we see so many other patients, in spite of you doing a cord vitrectomy, the attack reoccurs and the pressure goes up. So then what are you going to do? Take the patient back to the operating room? Doing via the trabeculectomy gives me that option of shutting it down on the table. You have achieved your target of doing a postcapsulotomy and anti-vitrectomy. And if the pressure goes up, I open the trap site one suture at a time, very gently, so nice low-lying blood forms to avoid the corneal effusions that can have in these cases. Now lastly, in some of these cases, you may have to make them uniocular. take the dam lens out and do a complete vitrectomy to avoid this complication. Yes. Thank you.
Thank you, Dr. Ramesh. Now I invite Dr. Arjun to present his challenging case.
Good morning, everyone. So I'll be presenting a technique of using compression sutures in a management of acute eye drops. So as we all know that acute eye drops by definition is a sudden split in Descemet's membrane which leads to ingress of aqueous into the corneal stroma, and this long-lasting edema can cause infection, pseudocyst formation, corneal perforation and vascularization. So reattachment of these retracted Descemet's membrane to the stroma with endothelial cell migration leaves a visually impairing scar which leads to eventually a keratoplasty which the patient requires to restore the vision. So conservative management of acute eye drops include using hypertonic saline, topical steroids and anti-glaucoma medication. So descemetopexy has been advocated since long time with C3F8 or SF6 in small size eye drops. Intracameral injection of gas like C3F8 or FX6 has been reported to accelerate the resolution of edema, but this causes side effects like pupillary block glaucoma, cataract formation, intrastromal migration of the gas and endothelial dysfunction. And if we use a conservative management, it takes really long time for 2 to 4 months for the spontaneous resolution of the edema, and larger tears may take even more longer time and eventually they require a keratoplasty. So compression sutures in acute eye drops, it works by the mechanism like this shorten the edges of the Descemet's membrane tear and facilitate anatomical reposition. If you look at the photograph here, a partial thickness bite from a 10-0 nylon is taken, and care is taken that it doesn't penetrate full thickness of the cornea. And once we take a knot and the knot is opposed, so we can see that the Descemet's break is almost, it is anatomically reopposed to its normal position. And this compression effect of the sutures creates a belt buckle effect, what we use in retinal detachment surgeries, and the care has to be taken that these sutures have to be taken perpendicular to the Descemet's membrane tear, and the tear principles of the corneal tear repair hold good in this surgery also. So this is an example of a 32-year-old male who presented with a sudden loss of vision in his left eye. He was a known case of keratoconus, and there was sudden blurring of vision, and the presenting visual acuity was counting fingers close to face. You can see that the central cornea is densely edematous. There is a large cleft of fluid accumulation in the central part of the stroma, and you can see that the Descemet's membrane is shown there. And this is anterior segment OCT of the same patient showing a large cleft of the fluid accumulation within the corneal stroma, and the cornea is densely edematous. So this patient underwent compression sutures under peribulbar anesthesia, and this photograph is after a week after the surgery. So the surgery is done under peribulbar anesthesia, 10-0 nylon sutures were used, and before doing the surgery, the tear, the location of the tear has to be seen carefully on slit lamp. For example, this tear was from 2 o'clock position to 7 o'clock position. And when we are passing the sutures, we have to make sure that it doesn't penetrate full thickness of the corneal stroma, and it has to be passed perpendicular to the Descemet's membrane tear. To facilitate the surgery, air bubble is injected into the anterior chamber so that the torn Descemet's membrane is almost reopposed, and the needle is passed through the clear cornea, through the edematous cornea, and exited from the lateral clear cornea. And full thickness bites are avoided, and the number of sutures depends on the extent of the tear, and finally the knots are buried. So this is at 2 months post-op. You can see that all sutures are removed, and we can see the central scar and a small suture scars which are seen, and the best correctal visual acuity was 624, and later on this patient was sent for a contact lens trial. And this is ASOCT photograph showing the same patient, resolution of the corneal edema. The pre-op ASOCT showed a dense corneal edema. Now it is showing a very small edema with a small cleft of fluid and a corneal scar. This is a second patient with a similar problem. So you can see in the inlet, the sutures were placed with a full thickness air bubble in the anterior chamber, and the ASOCT shows a dense corneal edema. And this is after 1 week, the air bubble is in the anterior chamber and the corneal edema is started to resolve. So partial thickness compression sutures can be a first line of treatment for acute corneal eye drops. The sutures minimize the gap between the torn edges of the tear, which leads to faster resolution of the edema. The main crux here is the sutures have to be passed perpendicular to the Descemet's membrane tear to create a compression effect. And this technique shows a good anatomical and visual outcome in patients with keratoconus with severe acute eye drops. Thank you.
Nicely managed. Dr. Arjun, do you recommend compression sutures for all cases or just severe cases of...
So in the photograph which I showed, large tears with almost 7 to 8 millimeters of edema in the cornea. So large tears, I do recommend to put a compression
not
suture.
for all cases.
Not for all cases. Small tears, they usually resolve with conservative management. Large tears, because it takes longer time. So it's better to do this procedure.
Very beautifully done technique. The only problem is in acute eye drops, you do not know the breadth of that
Yes, sir.
area.
Yes.
Because whole cornea is edematous there in the center as well as in the paracentral area.
Yes, sir.
So it's very difficult. You need to take it from the normal cornea and go all the way down and get it on this side, no?
Exactly, sir.
Yeah.
And in fact, when we tighten the knot, when we are doing multiple sutures, the previous knots get loosened up because of the gross edema. It takes time. We have to do it very carefully. So.
Yeah.
Yes. The
And you have
sutures
to
have
place it very close to each other or what? Yes.
Yes. Sometimes if they are taken superficially, they can cut through. So we have to make sure that it is not too deep to perforate and not too superficial.
Now invite Dr. Thank you, Dr. Arjun. Now invite Dr. Srujana, who is a consultant at AIG, to present her case.
A very good afternoon to all the dignitaries. So I thank my mentor Dr. Swapnali and TOS for giving me this opportunity. So here I am presenting a challenging case of cornea. So this is a case of 40-year-old gentleman who hails from Andhra Pradesh, came to our hospital on 19th January with chief complaints of discharge, decreased vision and photophobia in both eyes. So upon the history, there was some history of foreign body fall 3 days back. Local doctor gave saline wash. Patient was diagnosed elsewhere as gonococcal keratoconjunctivitis in both eyes and started using moxifloxacin eye drops 4 to 5 times in a day. Systemic history, patient was only hypertensive. There are no other previous history of fevers, recent history of any urethritis or any other clinically significant history. Upon examination, the visual acuity in patient in both eyes was hand movements. Intraocular pressure was normal digitally in both eyes. There was complete restriction of ocular movements in all directions with severe chemosis and congestion. The cornea was shown in the picture. There was 360 degrees full thickness corneal infiltrate in both eyes. Entire cornea was edematous and there was large epithelial defect involving the entire cornea. Anterior chamber was deep in both eyes with an exudates and hypopyon. Pupil was mid-dilated and fixed, not reacting to light. Lens was cataractous. Fundus examination was hazy, so we have done a D-scan which came out to be normal, and the sac was patent. Corneal sensations, there was variable responses. We have done a corneal scraping in both eyes. The smears have shown gram variable bacilli. So we had a provisional diagnosis of keratoconjunctivitis in both eyes with the differential diagnosis being gonococcus, toxic conjunctivitis, viral, collagen vascular disease and the pseudomonas. We have evaluated the patient. Following investigations have been done, CBC, ESR, RBS, ANA profiles, everything came normal. Chest X-ray was also negative. And we have done a MAN2 test which is negative. Urine examination was within normal limits, no sign of any infections. Blood culture report was awaited and LFT was normal. So these were the initial clinical pictures of the patient on 19th of January. So we have started patient on fortified ceftazidime 5% half hourly, ciprofloxacin 0.3% half hourly and atropine 3 times a day. And on the further visits after 2 days, there was peripheral thinning noted inferiorly in both eyes and we have started patient on doxycycline 200 mg 2 times a day. And the next review, it has further progressed in infiltrate. So we have started patient on injection ceftriaxone 1 gram IV BD. So on 22nd, the culture came out as no growth and the HSV, IFA and PCR are also negative. On further visits between 23rd to 27th, we have noticed further increase in peripheral thinning and further epithelial defect was still persisting. Infiltrate was not responding, it was status quo. On 28th, as there was further progression of thinning, we have put tissue adhesive with BCL under local anesthesia and along with the same topical drops, we have added chloramphenicol 1% 4 times a day. So these were the clinical pictures after putting the BCL and tissue adhesive. There was increase in stromal cellularity. At this point, we were revising our diagnosis and we have stopped ceftriaxone and Cefalox eye drops and started patient on prednisolone eye drops 6 times per day along with other eye drops. So on further visits 2 days later, between 30th to 6th, we have noticed that the decrease in stromal cellularity, the epithelial defect was also decreasing in size, and we have continued prednisolone eye drops. On 9th, after 3 days, this was stable ocular surface. We have continued the prednisolone, chloramphenicol and atropine, and we've asked the patient to come for review after 4 days. When the patient came for next review, patient was not complaining to the treatment. He was complaining of pain and further decrease in vision, and the vision again deteriorated to hand movements with an accurate PR in both eyes. We again started patient on prednisolone, chloramphenicol and atropine along with CMC drops and oral doxycycline. With these medication on the further visits, the patient again has showed improvement in the visual acuity and the surface also started healing. Meanwhile, the urinary culture and blood culture came negative and urine culture has shown E. coli, but it is of insignificant growth. Patient was discharged with the same medication and advised to come for a review after 1 week. In the further visit, we have noticed that again there was increase in cellularity in both the eyes, though patient was complaining to treatment this time. We have continued the steroids and asked for review 4 days. So on further visits, we have noticed that there was further collagenolysis with thinning in both eyes. So we have advised the patient for AMG with tarsorrhaphy, meanwhile continuing the lubricant drops hourly. So right eye AMG was done initially, later on left eye AMG, right eye AMG with tarsorrhaphy was done, and the next day left eye AMG was done. Meanwhile, patient was continuing the lubricants and the prophylactic ciprofloxacin ointment for the tarsorrhaphy sutures. The patient's ocular surface was stable on the further visits. So these were the clinical pictures after the AMG and tarsorrhaphy. So overall, the patient was doing very well, and we have advised him to continue the same treatment. As suggested by the primary physician in view of patient general condition, we have repeated the MAN2, which turned out to be positive. So here the clinical importance of this repeat MAN2 coming as positive is this response is called boosting, where the initial MAN2 will be negative, but the later on MAN2 test came out to be positive. So that first test negative and second test positive suggest as previous infection or could be because of previous vaccination or any infection with a non-mycobacterium also. So physician opinion was taken and he suggested Cox infection cannot be ruled out. Unfortunately, after this we have lost follow-up with the patient. So now my discussion points for the panelist is what could be the etiology in this case? Are we missing any other systemic cause? How the cornea is going to behave in the future?
I have a question. Have you checked the corneal sensations in this case?
Yes, sir. It was variable response, sir.
Okay.
Cornea
So
was also edematous. So
this
it
is
was
a case which I told her to present because I don't have any answers. So if the panel here can give some suggestion.
So I've seen 2-3 patients like this over the many years, and of course we don't know what we're dealing with, but this looks viral in the presentation.
We
Yeah.
have done the PCR. HSV we have done the PCR also came negative, sir.
Any endogenous cause? Endogenous
Could be another virus. Yeah.
Rishi,
Yeah.
any endogenous cause is possible? Like endogenous endophthalmitis, like?
B scan was normal.
Normal.
The presentation is predominantly in the cornea and conjunctiva.
I know, but the patient is not immunosuppressed or...
No, sir. All the systemic investigations also came out normal, sir. No previous history except for hypertension.
Did you try any systemic antivirals?
Systemic antivirals, no, sir, we didn't
Maybe
try.
that, empirically you could have tried, that might have helped.
Exactly.
Yeah.
So I'm hope the next line of treatment I'm thinking is antiviral now.
Because
no blood vessels till now.
Yeah.
But then I think we have to try that.
Yeah.
What about systemic steroid?
Yes, sir.
Because it's like a Moran's kind of thing, could it be? I was just asking, it could be like a Moran's kind of thing and then developed a second thing.
Overhang.
Which was not.
Sometimes we call some diseases idiopathic, meaning that we are idiots and we don't know what the pathology is. And this is one of those cases. You do all the labs, sometimes it's going to show its face later on. I would not worry too much about it. I think the management is excellent. What you have done is what exactly I would have done. I've seen many cases. I do a lot of corneal infections in my life. I mean, and I deal with this day in and day out. And sometimes nothing comes out positive, and that's a good thing. They don't have a severe disease that they're going to die of. That's one way to look at life, right? And as to when to do, what to do, I think you already did. I would wait it out to see if the amniotic membrane graft is thin enough. Sometimes these patients can get 20/60 vision or plus, and maybe the patient is going to be happy. And at a later date, you can go ahead and do a cornea transplant depending upon the transparency and then the cataract surgery. But I do agree that an antiviral should have been tried.
Right.
Systemic, oral, you got nothing to lose. The side effect of acyclovir is pretty close to zero. So anytime I don't know what it is, I know what to do, which is I latch on to oral anticyclovir. Thank you. Great presentations.
Thank you, sir.
There was no cause of initiating the LSCT, no chemical injury, nothing, sir. I just hope the patient comes back in a better state.
I think it started responding to topical steroids. It should have continued intense topical steroids to see the response.
No, but then the thinning was progressing, no?
You had already put TABCL, no? And steroids you are using only 6 times a day. Probably you should have increased the steroids.
Oh, yeah. So that's why we thought of doing the tassorrhaphy. Yeah, let's see.
Yeah. Coming on to the next presentation, Dr. Varun.
Thank you, Dr. Nitesh. Boss, just connect this one. Yeah. So good morning once again, everybody. So I would like to present one case which is right now something we have been discussing all over. This is not moving. It's not moving. The slides are not moving. Please send each other. क्या हुआ? Slides are not moving. The other person start, don't waste time. No, Nitish, let somebody
Dr.
start
Rishi.
because it's not moving.
Dr. Rishi can start.
Can you get my laptop and connect it? It's there?
Off करके on करो. आपका सर आपके पास वो कनेक्ट कर देना सर के यहाँ कनेक्ट सर
Okay, it's here. Thank you. Thank you, Nitesh, for including me in this session. So, this is a cataract case, so I think it might be of interest to more of the audience. Yeah. So this was a 35-year-old male patient. He was a IT professional by occupation, and he had come to me in 2013. So this is quite an old case actually, and he complained of gradual painless loss of vision with glare in the right eye since 11 months, and it was more since 1 month, especially at night. He was diagnosed by a local ophthalmologist 11 months ago, and he had come for a second opinion, and the local ophthalmologist told him that he had cataract and needed cataract surgery and advised him a multifocal lens. So basically he had come prepared for a multifocal and he was very, very keen on it. And this is how his eye was, 6/9 parts in the right eye, 6/6 parts, and N8 in the right eye. And he had a significant posterior subcapsular cataract, more in the right eye. Left eye was mild PSC. Rest was all normal. So I explained the patient everything about the pros and cons of multifocals and glare, halos, and he understood everything, and he was very, very keen on multifocals. At that time, we didn't have any other options. We didn't have EDOF lenses. So we went ahead and put a multifocal lens in his eye. Intraoperatively, there was a PC dehiscence. Unfortunately, I don't have the video of that. So it was properly managed, anterior vitrectomy was done, and IOL, we managed to put it in the bag. It was stable at the end of the table. It was well centered, so we continued as planned. And post-operatively, patient was good, lens seemed reasonably well centered, and patient was having good satisfaction with the outcome of the surgery. Now 3 months later, he comes back to me with glare and halos in one area, in one quadrant of his vision. And he was very symptomatic, in fact. And when I saw him carefully on the slit lamp, this is how it was. So that you can see that the lens is slightly decentered, and you can see that the rings are visible on one side, and one side you can just see the central part of the multifocal lens. So obviously this was the cause of his complaints, and this is why the patient was unhappy. Now, why did the lens decenter? We know that when you have a posterior capsular dehiscence, your centration will get compromised to some extent. As the bag fibroses, it will move the lens a little bit, and especially if your anterior capsule has also had a loss of integrity, then more so it can happen. So after dilation, that's what the eye looks like. So you can see the posterior capsular dehiscence there. So lens is well in the bag, but there is fibrosis at one edge of the tear, and I think that has pushed the lens a little bit. Now, what would one do at this stage? Maybe I can ask the panel and then we'll make it a little interactive. What would the experts do for this patient? His vision is still good. He's just one quadrant he's having these symptoms.
When you have a cataract, when you do a cataract and we have PCR, I convert that into a posterior capsulorhexis. Whatever it is, yeah, because you have not shown the video, I have not seen.
Yeah.
So I would have converted that into a posterior capsulorhexis. Then I am very sure that I can implant the lens in the bag.
Yeah.
In those cases, the lens will not decenter. If you are not able to convert that into a posterior capsulorhexis, I would not put a multifocal lens.
Okay.
I would explain to the patient, you are not good for multifocal, I'd put a monofocal lens. Okay, you have done it. Now what do we do now? Okay, now the lens is a little decentered. You saw that pupil is also a little dilated. Probably during the vitrectomy or something like that it's happened. The pupil is also not normal size, and there is also slight irregularity of the pupil. So I have done a few cases now wherein I have just centered the pupil. So I have done something like a pinhole pupilloplasty. I do an SFT in 2 quadrants, and this I have learned from Amar.
But would that work for a multifocal if you make the pupil too small?
Yeah, we just get the Purkinje image
right
in the center. So you can just put one on top, because if you see the picture there, you can put one on top and then if necessary one on bottom, and then try to adjust that pupil. The Purkinje images will come in the central ring.
Dr. Chitra has a comment.
I wonder whether you could have left the haptic in the bag.
At that time there was, it is a bifocal, there was no trifocal at the time.
You could have probably left the haptic in the capsular bag and got the optic out as a reverse optic capture. And maybe a little amount.
So actually on table it was so well centered in the rhexis, the rent was so small that I didn't feel the need. If it was a bigger rhexis and all, of course I would have done all that.
No.
Yeah.
Now you can go back and do it if it's not.
Yes, so you're saying at this point you can do it?
How long?
It's this patient has been now operated for almost 3-4 months now.
Only
so
3-4 months?
Yeah.
You can just release the capsule margin, if
Right.
any adherence, and
Sure.
get the optic out.
Okay.
Getting the optic out in a single piece multifocal is It's possible. It's very difficult.
Yeah, it's not
very
easy.
difficult. It's because there's no angulation that lens.
It tends to go back, even if you.
Yeah, it tends to go back, and there is no guarantee that you sing. If you want to retain that lens, the only thing is I'll play around with the pupil now.
Yeah.
Right. There is a drug, one of the oldest medications ever known.
Pilocarpine.
Pilocarpine. Try the damn pilocarpine and let the patient get adjusted to his mind. Sometimes that's all.
No, sir. The problem. I've done that in a few patients.
But if it does not work.
No. The problem is the patients complain of severe eye pain after some time.
So.
No, Sudafix only, madam. I have done it, and they're not. Yeah.
So here is one tip. Pain that is unannounced is more likely to be complained about than pain that is educated about. So you tell the patient to expect headache for the first few days, take some Tylenol, whatever, in anticipation of the headaches. They will get used to it. Pilocarpine has been used in glaucoma world for how many years, right? And they do tolerate very low strength pilocarpine. That's all that you probably need. And at least you give it a shot and the patient may say, okay, I'm quite happy. You proceed with other eye multifocal. Now the brain is all set and they may not come back to you. If it fails, then I do exactly what he suggested, the pupilloplasty.
Yeah.
Ever so simple, the Tamar technique.
Yeah, at that time, even that technique wasn't there. But I'll tell you what I did. So I decided
Another technique that I would do is a slit lamp, 30 gauge needle, to recenter that. I've done that. I promise you, I've done that. Recenter the optic in such a way at the slit lamp by pushing it. But post fibrosis, it may not.
It may not move. Yeah. So in this case, I decided to try an argon iridoplasty and just move the iris a little bit. So we did these kind of shots with these settings, and you can see that there was 10 days later when I saw the patient, he said there's 50% improvement in his symptoms, and you can see that you can see some rings on the other side now. So it was a little more symmetric, and you can see that the decentration is a lot lesser when you see on the slit lamp. Of course, on this side, I'm not sure you can see the pointer. On the other side, you have more rings, but it has become a little more symmetric. And at 6 months, when this patient came to me, he said he's completely free of those glares and halos, and he was actually, after that, I've now seen him for 10 years. He's never complained again, so he's doing well. And we did the other eye also. We put a multifocal. He's very happy.
Rishi, I'm happy that the patient is happy, but the mechanism that you're proposing is not the way it worked. I think his brain got accustomed.
Exactly,
to the way.
because
did something, patient thought.
I've only moved the pupil. I have not moved the lens.
Actually, iridoplasty, when you do iridoplasty, the pupil dilates. It never constricts. So the proposed mechanism that you're proposing here is not correct.
So I've dilated the pupil on the other side and made it symmetric on the lens. That's what I've done. Yes.
That.
Yeah.
So you just stretch the entire pupil.
Yes.
You could have done that by the cyclogel, weak cyclogel, right?
Yeah.
So my point to you is, given time, a lot of these patients
will anyway settle.
Yes.
Yeah.
Yes.
Very innovative way to manage, Dr. Rishi. I think you do a publication of this case. Yeah.
Mike.
A simple WhatsApp cut in the opposite direction that works well in such kind of patient.
The basic, of course, you are lucky. Your patient is also lucky, I would say, because basically, when you have a multifocal lens, please don't dilate the pupil. If you're going to dilate the pupil, more aberrations will start coming, and more halos will come. So you are actually dilating the pupil on one side to center it. Instead, I will constrict the pupil, either by medication or a permanent remedy by a SFT or a pupilloplasty.
My fear was already one side of the rings were completely covered in the pupil. If I constrict it, only half of the central zone would be under the pupil, and that would have actually made it worse, is what I was afraid.
You can actually see the Purkinje images. We can do that very nicely. But anyway, your result is good.
Thank you, Dr. Rishi. Thank you, Dr. Mohan Rajan.
Patient is happy, ultimately.
Dr. Charuta, you are present.
Good afternoon, everyone.
Dr. Vanita, can you come here? Chairperson. Okay.
So I'm going to take only 4 minutes as promised. And this is a very interesting case. A young 25-year-old female presented to me with dense amblyopia. So the question is amblyopia in adulthood resistant to treatment or not? And these were the questions that went on in our mind. And the prevailing consensus is that it's only possible if it's the amblyopia treatment is done before the closure of critical period, which we think is 10 years. And treatment beyond that is having very limited benefit. So this is a very young, beautiful looking 25-year-old female with a dense corneal scar. She gives a very vague history of having trauma in childhood. After that, some surgery, maybe repair done along with placement of an IOL intraocular lens. And progressively the scar kept worsening and becoming more and more dense. So we did a B scan and looked at, we found IOL reverberations. And since the visual acuity was hand movement, PR was, sometimes she was telling nasal, sometimes not. We went ahead and did a VEP which showed good reproducibility on the flash VEP. Now this patient, we explained to her that look, she wanted a cornea transplant and was willing to put in the work for that. But even with a guarded or a very, very, very guarded prognosis also, she was willing to take that risk, and we looked at some literature and thought that maybe amblyopia management, newer modalities would be useful for her. So with that in mind, with the diagnosis of pseudophakic corneal edema with secondary, with a sensory exotropia, secondary glaucoma and dense stimulus deprivation amblyopia, we went ahead and planned for a penetrating keratoplasty. So the plan basically, what was told to her was first a penetrating keratoplasty followed by selective suture removal after 3 months post-operatively, a toric contact lens maybe at 6 months post-operatively, and then vision therapy for 30 or 40 sessions followed by squint surgery. So injury in childhood, so we knew that injury in childhood meant that the amblyopia was probably dense, but the pro was that she was having a sensory exotropia and not esotropia, which we generally see when infants are stimulus deprived. Second thing was astigmatism correction post keratoplasty was going to be required in order to even try for the amblyopia therapy. And of course patients before surgery say yes to everything, and compliance on a continued basis to medications, consistency to follow the schedule was still doubtful. And of course we still think that the dogma is that amblyopia is an untreatable pathology in adults, but recent studies in animal models and clinical trials have actually challenged this picture. And it provides exciting evidence that intervention strategies boosting brain plasticity in adulthood may actually allow us to treat amblyopia in adults as well. Now, how it turned out was, if you can see in the image, the graph turned out well. We did a selective suture removal. A toric contact lens was given at 5 months. Visual acuity with the contact lens was around 6/60. Vision therapy, she completed 14 sessions. Then she was lost to follow-up for 2 months. Then she came back because she had discontinued due to health issues. And then another 10 sessions were done. But despite all these variations in our plan, her visual acuity improved to 20/80, and she was very happy with that. And after that, we even saw that the exotropia, a little bit of the control improved. She then further underwent squint surgery with a squint specialist, and she developed secondary glaucoma. After the squint surgery, it worsened because of the steroid usage, and then the vision fluctuated between 20/80 and 20/200. Now, the best BCVA had been 20/80, and selective suture removal, we could give her a prescription. So the pluses in this case that turned out was the best BCVA documented. We could achieve 20/80 despite a PR inaccurate pre-operatively, and we could actually give her toric contact lenses as well. And secondary glaucoma actually demotivated her and us as well. And graft edema now, further follow-up 2 years later, she had graft edema, and poor compliance to AGM prompted us to convince her to go ahead now with a trabeculectomy for managing the glaucoma. The theory of dichoptic training bases on the concept that the binocular circuitry from the weak amblyopic eye is actively suppressed by the strong fellow eye. So the dichoptic training actually the dichoptic training involves tasks that reduce the fellow eye contrast, and therefore it rebalances the contrast between the two eyes. And when the inhibitory interactions within the visual cortex are all reduced, therefore the patients the outcomes are much better. Therefore, we theorize that in this case also this is what we saw and was the reason for improved outcomes. So, sir. So she gives a vague history, maybe 5 years or 6 years of age, she doesn't remember. Scar. So the history she gave is that recently there was worsening of the scar. In the recent years, the scar became more dense. And she had some vision, but it became progressively worse. Sure, sir.
But nowhere in the management, excellent case by the way. I mean,
thank you, sir.
Very few ophthalmologists in this day and age are paying attention to these kind of patients. Why? Because we get, whatever the charge is for the multifocal lens, nowadays it's 5-minute procedure, we all latch on to that and make money out of it. But the real meat of ophthalmology is in cases like this. And congratulations on spending the time with this patient.
Thank you.
But one comment I have is this, nowhere in the management, in the initial slide did you say management of glaucoma. What I would have done is to reverse this paradigm. I would have treated the glaucoma first before I opened the eye. The risk of suprachoroidal hemorrhage in an eye like this, open sky, when you do a cornea transplant is super high. Okay, so you always think about that. When there is glaucoma and there is a corneal scar, the chamber is collapsed, the thing that goes through my mind is, if I do a cornea transplant in this eye, am I going to lose this eye on the table? Nothing worse than the patient who thinks, Dr. So-and-so is the last person who touched my eye, ended up with losing not only the vision, but the entire eyeball got out, right?
So we did give her aggressively anti-glaucoma medication.
But my point to you is this, aggressive anti-glaucoma medications are not going to be effective in the post-op period, which is exactly what you're finding out. So what I would have done is to do a surgical procedure to control the glaucoma prior to your transplant, and then do a transplant surgery is what I do. And two, at this stage, I would strongly recommend, if it is possible in your setup, to consider doing a keratoprosthesis. They work extremely well. You can avoid all this drama with toric lenses and everything else, but manage the glaucoma properly. And two, go with the keratoprosthesis. You will restore the vision. Whatever vision that she has, it's going to come out on day one, as long as the surgery goes well.
So I have limited experience with keratoprosthesis, but the cases that I have seen from others also do come with glaucoma. And in fact, that is one of the most common cause of losing
tubes at the same time.
That's why I
we
said,
do the tube with the keratoprosthesis.
Yeah, that's why you manage the glaucoma with the tube first, and then do the keratoprosthesis. Whichever way, you cannot escape glaucoma in these cases. The number one reason why a patient goes blind in the long term following any kind of cornea procedure is what, my friend? Is glaucoma.
Yes.
Manage it very well, because we see this so many times. I do everything anterior segment. There's nothing that I don't do. Yes. I tell you what, the most important thing that we all miss out is management of glaucoma. Take care of it first and foremost, and then do everything that is vision related in terms of cornea transplant. I think we'll be doing a service to the patient. And the patient will retain the vision in the longer term. Thank you.
Thank you. This well done, patient. Only thing is, the take-home message what you said, Charita, is that there is no age limit for amblyopia treatment,
yes,
my
sir.
opinion.
Yes,
I've had a 45-year-old patient who lost the normal eye with road traffic accident. Other eye was 6/60, dense amblyopia since childhood. Became 6/6 in 1 year.
With vision therapy.
Became 6/6.
Yes.
I didn't do anything. Automatically it became. Yeah. So there is a role for occlusion. Because the other eye became blind, normal eye became blind. It was working like an occlusion therapy for him. So 660 to 66, 696 plus. So I was very surprised. So I don't, patients come at 35, 40 years also, I give them partial, part-time occlusion as well.
Yes, absolutely.
Vision therapy is there, available,
yes,
online, so it's there. And I think it works very well.
Thank you.
But wonderfully done.
Absolutely, sir. I agree with you. One comment, please. This neuroplasticity is just a relative term. We had also treated so many adult amblyopia patients successfully using the orthoptech magnocellular stimulator therapy. And also before going for the squint therapy, we can go for the orthoptic because that decreases the degree of deviation also.
Yeah, we did the same actually.
Yeah.
In fact, we
So
found that the degree of exotropia
it's just a relative
yes.
term. The adult myopia, they do respond well.
Thank you, Dr. Maurya. Now I invite Dr. Varun to present his challenging case.
Thank you. Just come. So good afternoon, everybody. I'm back with my second presentation, and it's on phaco dilemmas in glaucomatous patients. So we handled a couple of patients in our clinic. So this was a 35-year-old male who was a known case of Sturge-Weber syndrome. He had undergone a brachytherapy for choroidal hemangiomas at our oculoplasty clinic in Center for Sight. He was on anti-glaucoma medication since 2006, on Dorzox-T twice a day, brimonidine twice a day, and Iopar. He was a one-eyed patient. He was actually sent to me for a cataract surgery, but unfortunately the patient went outside and had the cataract surgery done elsewhere. And he came back to me for a follow-up after a month, where he started complaining of decrease in the field of vision 15 days post-operatively. Pre-operatively, his documented vision was 618, not improving, and now his visual acuity was 636, not improving any further. The IUP recorded by the non-contact tonometer was 12 millimeters of mercury, and so I referred the patient to the glaucoma clinic, and fortunately the glaucoma surgeon is right here with me in the hall itself. So this was the patient. As you can see here, the patient had choroidal hemangiomas. He had a classical port wine stain. And what we also found is that the patient had limbal relaxing arcuate incisions in the cornea, which actually did not allow the glaucoma surgeon to record the intraocular pressure correctly. The findings recorded by the glaucoma surgeon was episcleral congestion, a mid-peripheral limbal relaxing incision. The intraocular pressure on applanation was 21, but it looked higher digitally, 360-degree peripheral anterior synechiae. The disc had a 0.85 with a superior notch and significant disc pallor. So we then started thinking about a wipeout following a cataract surgery, because the patient had underwent a femto-assisted cataract surgery, and there is obviously a transient rise in the IOP during the procedure, and the patient was already glaucomatous on AGM. So as you can see, these were the disc photos pre-operatively, showing you the superior notch here. The patient was asked to continue the AGMs, and oral steroids were started, 60 milligrams taper every 5 days, and patient was asked to come for a close follow-up. Well, post-steroid treatment, these were the discs. So this is for Dr. Vanita to comment if there was any improvement in the discs, but eventually when we repeated the fields, there was a mild improvement in the visual fields post the treatment. The second case, which was absolutely diverse, was another patient. I saw a 56-year-old female, and she kept on complaining of blurring of vision in the left eye, persisting after a cataract surgery. She was also on AGMs for the last 3 years. The intraocular pressure recorded was normal. The best corrected visual acuity was actually 6.9N8. So quantitatively, the patient did have good vision, but the patient was persistently complaining about a poor quality of vision. So patient had a Technis Symphony lens implanted in the bag, and you can see these were the disc photos. So technically, when you put a multifocal lens in a patient with glaucomatous disc, it is a trade-off, though the patient may become fairly spectacle independent, but the quality of vision tends to go down. So is it okay to put a multifocal lens in early field defects? Well, though various studies state that glaucoma is not an absolute contraindication, but personally speaking, I would definitely avoid any of the multifocal lenses in a glaucomatous patient. There have been studies which say that if there is a non-progressive glaucoma, if the IOP is stable on 1 or 2 AGMs and the patient is compliant and very motivated, you can actually go ahead with it. That's what the studies, I've come across a few studies, but though personally I would not recommend that at all. In patients with advanced visual field loss, I think it's better to go for accommodative monofocal lenses and aspheric monofocal lenses. You can nowadays use eye hands, which gives good intermediate vision also. The patient can still use reading glasses for near vision. So the points for the anterior segment surgeon here are always avoid limbal relaxing incisions in glaucomatous cases, because it makes difficult for accurate IOP to be recorded. it is better to do a manual phaco in a already compromised disc. I mean, why to risk it with the femto-assisted cataract surgery? Start oral steroids to recover some field of vision in case you suspect a wipeout, and obviously take your glaucoma colleague's opinion pre-operatively. It's always better to work as a team. And as my little experience in life has taught me, most of the problems and arguments can be resolved over drinks. Thank you. So I would like Dr. Vanita to add to this case, because this is a case we had managed.
What femto machine you used, Catalyst or Lensex?
So we use Catalyst.
Catalyst. Catalyst doesn't increase the pressure much.
No, but
about
this
10
was done
millimeters.
elsewhere, sir. I didn't do
Done
this surgery.
elsewhere.
It was done somewhere else and it came back to us.
Generally,
But I
femto
would
machines don't increase the pressure much. Generally, the femto phaco machines.
The Lensex increases
No, your
because it's solid interface.
Yeah, but it's around 20-25 millimeters,
No,
not more than that.
it goes
10
up to
millimeter
50,
is
60.
Catalyst 10 millimeter.
Yeah,
10 millimeter Catalyst.
Yeah.
I use only Catalyst.
Literature says 50 to 60. It
No,
can go
no,
up
no.
as high as.
No. Catalyst is only 10 millimeter, madam. But Lensex is little more, 20 millimeter or something like that.
Right.
Solid interface with liquid interface.
Right.
But
Okay.
another reason is what machine you use, whether you use any active fluidics during surgery, whether the bottle height was more, all these things.
Surgery
I
was
think
done elsewhere, so that
done
is a
elsewhere. I'm
limitation.
just asking. No, since you have raised the question, and I'm sure no multifocal for glaucoma patients. That's very sure, especially ring lenses. You can have an EDOF lenses, non-diffractive. I've used some Vivity, but not for advanced glaucoma like this. Definitely.
I would just like to extend what Dr. Ramesh Ayala was saying, which is very correct, is that actually it is the glaucoma that determines your outcome. So if there is any situation where there is preoperative glaucoma, if you do not get a glaucoma opinion, and if you do not appropriately manage it, at the end of the day, whatever beautiful surgery you do, patient is not going to end up with good vision.
Correct.
So glaucoma has to be managed before, not after.
Absolutely.
So,
Hit the nail on the head.
So in the first case, instead of AGV, this very bulky Ahmed glaucoma valve implant, I would like to go for Omniflow glaucoma drainage device because it's very small. And we are talking about interference diffraction, so there are rings in the multifocal as well as the trifocal, so we can go for autofocus pro. Right, it is a ringless polyfocal progressive IOL, so we can go for that if the fields and everything they are good. Right.
Right. So one point about doing surgery in Rajbhavan syndrome. It does not matter whether you do Ahmed valve or you do any other outflow pathways, you will end up expect choroidal effusions. And when you do this, you better do a scleral window to avoid doing that. A slow release. Anytime you do operate on a Rajbhavan syndrome from the glaucoma point of view,
Right.
you be prepared to marry that patient because you'll be seeing that patient for a long time.
For a long time.
So be prepared. It does not matter whether you use a small device or a big device. The point is, it does not matter whether you do the mini brass or you do the Ahmed valve. Initial post-operative control is the key to avoid choroidal effusions, and sometimes there could be massive, sometimes you may have to do a scleral window to avoid that. And two, I do like extended depth implants in glaucoma patients, like the Vivity. I do have like mild moderate glaucomas.
Sir,
Mild to moderate glaucoma Vivity is okay, sir, but
Yeah.
no ring lenses.
No ring lenses,
Please
yes.
understand this. Ring lenses split the light.
Regarding
When
the
you want
Omniflow,
something to
sir,
split the light. Yeah.
regarding the Omniflow, sir, it will keep the IOP between 10 and teens only. It's not over drainage.
Look,
Yeah.
I've been doing this for like 30 years, 30 surgeries every week. And I
Yeah.
can tell you, there's no device that can give you predictable results in any case.
I will give you, provide you some samples, sir. Kindly use them.
Listen,
Thank you.
my friend. All I can
No,
tell you is this.
autofocus.
No, Omniflow, sir. Omniflow glaucoma drainage device.
Omniflow, I'm not sure, but autofocus really, it's a lens for this particular case.
There is no surgery that can give you a predictable IOP and then continue at that rate in any complex glaucoma, period.
We had,
used
done a clinical trial, sir. Result will be out very soon.
Sure.
Thank you, sir.
Thank you.
Coming to my presentation. Yeah, coming to my first case, I had a 55-year-old female who came to me with complaint of pain, redness, watering and blurred vision in the past 1.5 months. She had history of undergoing cataract surgery, and subsequently she underwent, no, I have changed. Hooray. Acha, it's there on the main screen. Yeah, it's there on the main screen. So as you can see, patient had undergone 4 retinal surgeries, and she was on fortified antibiotic drops for the past 10 days. The culture had grown Streptococcus pneumoniae, which was sensitive to all antibiotic drops. And this is the clinical picture of the patient after being treated for 10 days on fortified antibiotic drops. As you can see, there is dense central infiltrate, and there is peripheral vascularization as well. So what I did in this case was I tapered off all the antibiotic drops, because 10 days of fortified antibiotic therapy is more than enough to manage any case of Streptococcus pneumoniae. And as you can see, after I discontinued the antibiotic drops, the central infiltrate has reduced, the epithelial defects has resolved, and the vascularization has increased as well. But I started the patient on topical steroids, and you can see at 2 months there is significant whitening of the eye as well, and the patient was symptomatically better. And the patient had not a good visual recovery, because he had undergone 4 vitreoretinal surgeries. So the eye was filled with silicone oil, so there is no chances of eye going into phthisis. Coming to my second case, I had a 25-year-old male with complaint of redness, watering and decreased vision since 1 month, and the patient was diagnosed as Pseudomonas keratitis and was treated with intense moxifloxacin drops for the past 1 month. And you can see there is a central infiltrate with surrounding edema and scarring as well. Since the patient was treated for 1 month of antibiotic therapy, I discontinued antibiotic drops. I just put him on chloramphenicol eye drops, which is supposed to be the least epitheliotoxic drug, and with intense lubrication therapy. And you can see that in 3 days, the epithelial defect has started resolving, the congestion has come down, and the patient is much better. And in 10 days, you can see that the epithelial defect has resolved almost completely. And at 1 month, you can see the density of scar has also reduced, and the visual acuity has improved to 6/60 as well. So coming to my third case, I had a 30-year-old male who came to me with the complaint of blurred vision since 2 weeks with pain, redness and watering, and the patient was on topical antiviral, antifungal and antibacterial therapy on 3 medicines. And this is how the clinical picture looked at 2 weeks. And what I did was I just stopped all the antibiotic drops, just put him on intense lubrication therapy, and the patient did have central corneal thinning as well, and you can see there is some peripheral vascularization as well. So I did tissue adhesive and bandage contact lens in this case, and the patient was also started on Acivir tablet in lines of viral keratitis, and you can see that at 2 months the adhesive has got removed, the vascularization has reduced, barring one segment of deep vascularization, and the patient was on tapering doses of prednisolone drops. And you can see at 3 months the density of scar is reduced, the eye looks much quiet now. And in conclusion, drug toxicity can present as chronic non-resolving keratitis with signs of ciliary congestion with infiltrate, hyperpion and a non-resolving epithelial defect. So whenever in doubt, it is better you give a, we call it drug holiday. You just discontinue antibiotic therapy for 2 days or 48 hours and then see how the patient responds or improves. And you can have coexisting HSV necrotizing keratitis, and you need to have a high index of suspicion in such cases. Thank you. Now I invite Dr. Mallika Goyal if there are no more comments.
Very well presented, Nitish.
Thank you, sir.
Yes, ma'am. Just give me 1 minute, I call you back.
So good morning everyone. Thanks to Dr. Nitesh for this opportunity. This is a patient who had a problem after an anti-VEGF injection. Okay, that's good. So this is a patient who received an anti-VEGF injection outside and presented to us 3 months after the injection, a 68-year-old lady who's been having symptoms of pain, redness and loss of vision for 3 months. Her first injection was on January 28th for AMD, developed redness which was treated by the physician, injecting physician as conjunctivitis, and the second injection of the same drug was given a month later. When she came to us, it was already 3 months since that injection, and she had severe redness, pain and vision loss since the second injection with raised intraocular pressure. But because of the vasculitis, we could believe it was probably inflammation, secondary to the injection. We did not start oral steroids not knowing whether it was infective and advised surgery for retinal detachment. The patient came only after 2 weeks, and this time she had very severe scleritis causing intolerable pain. So at this time, she also had a retinal detachment and vasculitis. We were able to add oral steroids because of the obvious scleritis. And that in a week's time led to marked improvement in symptoms and signs. Retinal detachment was settling down spontaneously and the media was much clearer. Retinal vasculitis was clear. So we realized that the retinal detachment was probably exudative and not rhegmatogenous because it was settling spontaneously. So encouraged now that this was not infection, we gave an intravitreal ranibizumab to take care of the occlusive retinal vasculitis and ischemia, and a periocular triamcinolone for the associated inflammation, as well as oral and topical steroids continued. And this led to a dramatic improvement within a week where the retinal detachment settled down, though now there was an RPE detachment. And now at this point we started scatter laser for the patient for the retinal vasculitis induced ischemia, and we have repeated another triamcinolone periocular injection because of the associated inflammation. So this was occlusive retinal vasculitis which has been reported post brolucizumab. The incidence is reported to be around 2%, though the overall inflammation following this drug is almost 10%, which is quite high. A very high index of suspicion is required because media is very hazy in these cases, so you cannot see the retinal details. And there are two issues which need to be tackled. One is inflammation that needs steroid, and the ischemia which needs another anti-VEGF, not the brolucizumab again. And as the media clears, laser needs to be added. However, before starting steroids, we need to be sure this is not endophthalmitis. And the most important points that were seen in this patient were repeating the same drug when there was an inflammation after the first injection. That should never be done with any anti-VEGF or any drug for that matter. Retinal detachment in occlusive retinal vasculitis can be exudative, so we should wait before proceeding with surgery for the retinal detachment. And there may be some hope after occlusive retinal vasculitis. Thank you.
Very nice, Malika. Only thing is, this happened 3 months after the injection.
No, the symptoms started immediately. She came to us after 3 months.
Oh, you came to you after. So it's mainly because of the anti-VEGF.
Totally because of anti-VEGF. Because even after the first injection, she had a problem, but it was repeated and then she lost vision as well. We saw the retinal vasculitis even at the first visit, and more clearly as the media improved, it was very clear. You're looking for retinal vascular occlusion. That's obvious as sheathed vessels.
Sheathed vessels.
Very obvious. Absolutely, it's known. Brolucizumab is known to cause occlusive retinal vasculitis.
Any role for intravitreal steroids?
Intravitreal, yes, if we are sure it's not
no, instead of going for another anti-VEGF.
No, see, these are two different things. The
Yeah.
steroid will take care only of the inflammation. But the intravitreal anti-VEGF was given for the vasculitis-induced
Component.
ischemia, which was causing neovascularization and will lead to other problems. So these are two different issues.
Yeah.
Steroid will not tackle the ischemia caused by the occlusive retinal vasculitis.
And you have done the laser also for that.
Yeah, laser is for the more long-term effect, and the anti-VEGF will only work for few weeks.
Wonderful.
Thank you,
Thank
Dr.
you.
Malka. Now
Thank you.
invite Dr. Hussain to present.
Thanks, Dr. Nitesh. I had a 57-year-old female patient who came for a second opinion regarding the glaucoma. She gives a history of having undergone a cataract surgery with a trab in the left eye in September 21, and then followed by that in the right eye, a phaco surgery with an eye stent, which was done in Jan 22, and then this was followed by maybe a high pressures, and in the same eye, endocyclophotocoagulation was done by the primary surgeon. So she was on both eyes using Diamox. Cornea was edematous, I don't know, they have written hypersol in the other place. The patient was also on brinzolamide, brimonidine, travoprost, timolol, and extra natalsodil in the right eye. So patient was on maximum medical therapy in both the eyes, including oral lestozolamide. The vision was like 6/60 N8 in the right eye and 6/24 N8 or N10 in the left eye. The intraocular pressures on maximum medical therapy were 26 in both the eyes. The gonioscopy showed multiple peripheral anterior synechia, and there was no eye stent which was seen in the right eye. In the notes written by the primary surgeon, they have mentioned that the eye stent is covered by a peripheral anterior synechia. So this was the fundus photo of the patient, showing almost 0.9 cupping with an inferior notch in the right eye and almost a 0.9 cup with a bipolar notch in the left eye. The OCT showed extensive cystoid macular edema with an epiretinal membrane in the left eye. So the fields were correlating with the disc, having a superior arcuate scotoma in the right eye and almost a early biarcuate scotoma superior more dense in the left eye. So with this, the diagnosis of open angle glaucoma bilateral severe stage, status post phaco eye stent and ECP in the right eye, and status post phaco trab in the left eye with both eyes cystoid macular edema, having an epiretinal membrane in the left eye was made. Now the clinical challenge was that patient had poor vision. There were already multiple procedures done. Patient was economically drained. Bilaterally had a high intraocular pressure on maximum medical therapy and was having additional cystoid macular edema as well. So what is next which could be done? The next which could be done was either a cycloablative procedure or a valve. But cycloablative procedure in presence of having a decent vision, and that too in presence of cystoid macular edema, is not advisable. So I decided to do a glaucoma valve for both eyes, right eye first, along with an intravitreal injection of an Ozurdex implant to take care of the cystoid macular edema. So the same procedure was done. The video is not playing. Anyways, I am running off the time. So post right eye phaco with Ozurdex implant, the vision up to 44. So similar procedure was done for the left eye as well. And after about 2 weeks of the treatment, after 2 weeks of the surgery, the left eye also showed a visual improvement of 6/18. The vision didn't improve beyond 6/18 because of the epiretinal membrane and residual cystoid macular edema. So with a single medication, that too to prevent a hypertensive phase, the patient had 14 and 12 intraocular pressure. So with this, the macular edema has resolved in both the eyes. The implant, the intraocular Ozurdex implant helped in this case, and I conclude that having a comprehensive approach addressing the comorbidities together can give an optimal surgical outcome even in the difficult cases. Thank you.
Thank you, Dr. Hussain. That was a very well managed case. Dr. Mohan Rajan sir needs to go to another session, so I invite him to take the
Yeah, good afternoon, everyone. So today I'll be presenting a peculiar case. A 46-year-old male, farmer by occupation, came from Andhra Pradesh with a chief complaint of sudden decrease in vision in the right eye since 6 days. He did not give any other ocular significant history and no history of walking barefoot in the field. So on examination, we could not see any entry wounds either in the hands or the feet. Best corrected visual acuity in the right eye was 20/125 N60, while the left eye was 20/20 N6. Rest of the anterior segment was within normal limits. As you can see, the best corrected visual acuity was 20/125. There was disc edema with flame-shaped hemorrhages, macular edema, some yellow-white lesions temporal to the fovea, and what was more glaring was a live worm which was sitting superior temporal to the fovea. But if you carefully examine, we took the fundus photo and then the red-free photo, the position of the worm was changing, which means it was motile. Though we were happy that we could see the worm, but the most important challenging thing was it was just sitting next to the fovea. So whatever treatment we are going to give or do laser, it has to exactly, the laser spot has to hit the head or the tail, because if we miss, because of the intensity of the light, the worm can move and reach the fovea, which we don't want in the situation. While the left eye was within normal limits. So a middle-aged man came with a unilateral diminution of vision with disc edema, multiple hemorrhages, multiple yellow crops of lesions, and a live worm superior to the fovea. So a diagnosis of diffuse unilateral subacute neuroretinitis in the right eye was made. We also did an OCT angio where we could capture the worm in the outer retinal layers. So what we decided is, first we have to locate the worm. So here you need to do a high magnification biomicroscopy using a fundus contact lens, and these are the parameters with which we did the laser. And as you can see, the laser marks, first what is important is we have to directly hit either the head or the tail. So after we did the laser, we captured and started the patient on oral albendazole 400 milligram once a day for 1 week along with oral steroids. So if you go through the timeline, this was a presentation. 1 week later, vision improved to 20/60 N12. 2 weeks later to 20/50. And 6 weeks later, vision improved to 20/30 N6. And you can see the laser scars and you cannot see any worm after 6 weeks. So what is more important is, when you see the presence of focal area of intense laser scars and fading of other white lesions after 7 to 10 days of treatment, it is an evidence of success of the treatment. So what is important in DUSN? There are two kinds of worms. This was a large worm, but you will not see such kind of cases so often. It is usually the small worms which move very slowly. You have to look at the hands and feet of these patients to look for any entry wound. So the classic presentation, though this was a very rare case where you could see the live worm, but the classic presentation is the single zone of mid-peripheral yellowish white lesions. So what you have to do is use a contact lens, and within the vicinity of those yellow lesions, you should look for any small worms which usually take the configuration of 6 or 9. That you can see only if you use a contact lens and carefully examine near the vicinity of the yellowish white crops of lesions. Sometimes they can present in the late stage like this, where you can see multiple RPE changes, a prominent ILM folds, that is the orifice sign, sometimes the tracts. This is the tracts where the worm has moved and released the toxins. So that is nothing but the Garcia sign. So not every DUSN case presents to you with the live worm. They can present in this late stage as well. So in the late stage, there will be outer retinal involvement with RPE loss and also inner retinal involvement with loss of ganglion cells. Sometimes you may be confused with retinitis pigmentosa. But as you all know, RP is usually bilateral and they have history from childhood or a long period of time. This is usually unilateral. So how do you treat? When the worm is visible, like in our case, photocoagulation is the treatment of choice. Smaller worm, it is easier to kill. Large worm, as you can see, we have to exactly hit the head or tail. Otherwise, if it reaches the fovea, those toxins are released and they may lead to RPE atrophy at the fovea. So useful sign to detect if laser is directed on the worm, you should use a slower uptake of laser heat energy with fleeting translucency within the opaque laser spot. Now what if the worm is not visible, which is a most common scenario? They only present with mid-peripheral crops of lesions. You have to look for the vitritis. Why? Because if the vitritis is there, it means the blood retinal barrier is already broken and you can directly start the patient on medical management with albendazole. But if it is not, then you have to break the blood-retinal barrier, you have to do scatter photocoagulation to those multiple crops of lesions, and then start the patient on medical treatment, which will have a better outcome. Thank you.
Thank you, Dr. Navya. That was a very interesting case.
Thank you.
Now I invite Dr. Raman to present his case.
So, thank you so much for the invitation, Nitish, and the Scientific Committee Chairman, Rishi, and TOS. I will be speaking about the decades of diplopia resolution made possible. Sometimes, in acute, in adult patients, after the onset of the granular nerve palsies like third and sixth and fourth nerve palsies, they do suffer with the diplopia if the recovery is not possible or there is a partial recovery. Okay, they pose many challenges in maintaining the balance and then in maintaining the compensatory head posture, and it is a continuous process and a lifetime process. So I will be presenting here two cases. In the first case, there is a 42-year-old male patient presented to me with the complaints of occasional double vision with occasional compensatory head posture and on the toes also. When he is looking to his left, especially he is troubled with that, and he met with an accident when he was at the age of 20 years. Okay, and he was in ICU for more than 1.5 to 2 months period. Later, when he recovered from the ICU, then he noticed that there was an outward and downward deviation. Deviation was about 90 prism diopters of exodeviation with 20 prism diopters of hypodeviation. And ptosis has two components. You can see here the old photographs when he was 20-year-old. You can notice here picture. And then this is a present picture, what before the intervention was done. Yeah. So you can notice here ptosis and the downward deviation, almost 90 prism diopters of exo and then 20 prism diopters of hypertropia. And cover, uncover and orthoptic evaluation shows that there was a predominantly a pseudotosis with a true ptosis component. And on motor evaluation, we found the inverse Duane sign. You can notice here on attempted adduction, you can see here the palpebral fissure height is increasing. So there is no need for ptosis correction later on. Okay. So this case was, FDT was positive and this case was taken for sensory evaluation shows that majority of the times he is enjoying the only uniocular vision because there is such a large deviation, the ghost image was falling out of the field of vision. So, and he had the cranial seventh nerve palsy also, but that has partially recovered and covered color vision also affected because of the some amount of optic nerve damage. And fourth nerve involvement is ruled out. And these are the fundus pictures. We can see in the right eye there is some amount of disc damage is there. So finally we took up the case for the fixation duress of the left eye LR ration of 10 millimeters with MR resection of 6 mm was done. In the right eye 10 millimeters of LR ration with inferior rectus of 6 millimeters ration was done. So the left eye left for the fixation duress. So post-operatively you can notice here there is a significant improvement in the deviation as well the ptosis is also got corrected. And in the second case he is a 57-year-old male patient. He had an injury again, landed in with right eye 6 nerve palsy showing uncrossed diplopia and diplopia charting and FDT was positive. Now he is 52-year-old. You can see here the pictures where there is a gross limitation of levo version on dextro version in the right eye and dextro elevation and depression limitation is there and the deviation is about 90 prism diopters and almost 2 decades old cases. Both cases are 2 decades old cases. So here in the left eye I did a 7 mm MR revision with modified Nishida with LR plication. So with this operative procedure you can notice here there is a significant improvement in the achieved orthotropia. Not only that but we achieved the abduction also. We achieved all range of movements. Okay, in the discussion part, the modified Nishida is going to be, nowadays is emerging as a modality of choice, especially in 6-nerve palsies. And here the special feature of this case is a 90% after deviation, almost 2 decades old case. But then still I attempted to do it, and fortunately we achieved such a great result, and patient got relieved of diplopia, and as well we achieved the orthotropia, and then compensatory head posture also got resolved in both cases. So with this, the take-home messages are how old may be the cases, but if we do, especially in the, if we customize the treatment, then probably we'll be able to achieve sometimes good results. So we never let up our efforts to treat the patients. That is my take-home message. Thank you very much. Any doubts, please, you can ask me.
Thank you, Dr. Raman, for an excellent presentation. Thank you, sir.
Discussion. Any questions? I invite questions from audience. Any question is there, I'm ready to answer. Regarding surgical procedure. Okay.
Right. Thank you.
Right, thank you.
Thank you, all of you. I think that is, with that we end the session. Thank you.
Always great, sir?
Always, as usual.
Always great, busy and rocking. IT people, I need a connector, audio and video, both.
Connector. Video भी, audio video दोनों. Connector. हाँ. Connector ले आओ.
मेरे पास
ऑडियो का भी वो अलग होता है. हाँ. I know. Hello. Yes, ma'am. Ma'am, which ma'am, you can upload in both the halls. You upload your and tell them the AV people. There is a hall B, right? Hall B and hall C. There is a AV people. Tell them, tell my name, and they will allow you according to your order. No, मैम आपको पहले सोलो वीडियो देना है ना. आप और टीवी का सोलो वीडियो करके and then you come back and leave. मैं hold D. Hold. Ma'am, they will not follow. You just do one thing. Upload it. Upload it. If you upload it, they will not follow. If what's the timing, ma'am? 2 to 4, 3 to 6. Okay. I will be there, ma'am. You just go to the AV section in both the halls. Upload your paper. I will be there. Yeah. स्नेहा, क्या हुआ? क्यों?
यहाँ का कुछ भी नहीं थंडरबोल्ट లేదన్న थंडरबोल्ट కేబుల్ లేదంట ఇప్పుడు అడిగినా 2 నిమిషాలు అన్న ఇట్లా చేసుకుందాం
अरे ये सर को पूछ के लो ऐसे नहीं लेते फिर पागल हो क्या कुछ भी नहीं करते इसमें where is the table smell?
अरे यहाँ पे पूरा एडवांस्ड होता है
साउंड आ रहा है
ना उसको ना ना साउंड
म्यूजिक है थोड़ा सा और लास्ट में है पूरा
ये स्नेहल स्नेहल
फुल कर दो फुल कर दो आवाज नहीं आ रहा है वॉल्यूम इज नॉट देयर उधर से नहीं है इसमें है
सुनो ठीक है आराम
यस सर वी आर गुड टू गो
So, good afternoon. Hope you had a good lunch. So now you have a feast for your eyes as well as your brain because we are having this near live session, which means it's a deferred live surgery. You always have seen live surgeries where a lot of things go wrong because the people are not operating in their own familiar setup. And many a times the teaching fails in an attempt to showcase their skills in an unfamiliar place. Many a times the audience do not really get the actual gist of what has to be taught. So this is a great idea to have a deferred live surgery. We have some expert surgeons who recorded their surgery in the comfort of their own OT. And now we can always stop, pause, discuss, go back, have interaction during the surgery, which is not possible in a live surgery, because that will be a disservice to the patient who is getting operated live. So we start with the opening batsman, none other than the Dr. Arvind Maurya, who will be showcasing his case on Autofocus Pro, a cataract surgery using that the phenomenally famous as well as the new kid on the block, that is the Autofocus Pro. And we have Dr. Jagdeep Kakadia with me, and also Dr. Rakesh Shakia and Dr. Praveen also.
Praveen.
So they will be actually joining me in moderating this session. Here we have 20 minutes. I don't think Dr. Maurya takes 20 minutes. He will take 2 minutes for his cataract surgery, but they have given him 20 minutes because it's a deferred live surgery. It's not a live surgery. So we can definitely, if you have a doubt, you can always ask. And Dr. Maurya can, stop his presentation and actually clear the doubts. Over to you, Dr. Arvind.
Thank you, sir. So good afternoon, ladies and gentlemen. So I will start with my deferred live surgery. So this was a case of pseudo exfoliation, a near mature cataract. So, and that patient wanted a spectacle-free life. And he was a retired government official, so we did biometry. So it was not possible through the undilated pupil. So we dilated the pupil, then it was possible to do the biometry. So this you can do in your practice. And there was very less astigmatism in IL power 23. So you can see the pseudo exfoliating material accumulated at the capsule. So I tried to dilate the pupil. Pupil was mid dilated, so I'm instilling Phenocaine plus, but it was of no use because in pseudo exfoliation it rarely works. It's still mid dilated. It's just the initial thing we are telling the patient to fix his eyes. So we waited for 1 minute to get the pupil dilated, but it was of no use. Then 0.06 trypan blue dye. And after cohesive viscoelastic in the chamber, 2% over the cornea. And then I initiated the capsular access. In capsular access, it needs to be minimum 4.75 to 5.25 to avoid phimosis, capsular phimosis. It's very common in pseudo exfoliating patient. So I was doing it very slowly. Half clock hour control. In such cases, we can use microcapsular access forceps also, but that was not autoclaved on that particular day. That gives better control. And now the access, it was coming out, so again I need to push the cohesive viscoelastic. And now I can go ahead. Any question, whatever you can ask in between?
What do you advise for beginners like postgraduates or fellows, like Rexis forceps or needle capsulotomy?
Yeah, I means for them it's microcapsular forceps gives better control, and they can go for Uttarata forceps also.
Because this step would be easier with the forceps to kind of pull it.
Yeah. It's definitely
I think
much easier.
They should learn both, because when you need to salvage, you have to tear, not shear. And for that, you need to know how to use a forceps. But I think it's also good to know the needle shearing technique. So I think they have to learn both.
And you're using the side port or the main port?
This is side port. It keeps the anterior chamber depth very well, along with the cohesive viscoelastic. Is the side port.
To Do you move towards the side port and sit that side, or you do with the hand extended like that for ergonomics?
Yeah, for ergonomics, means we are telling the patient, because it's under topical, to center his eye, and then we can go all around 360 degree. And this is the main port, using 2.4. And then one more side port, very small side port. It's a grade 4-5, so we need chopping. And then hydro dissection, very gentle at multiple places. And central tapping to keep the posterior that pressure at minimum level. And it needs to be done under direct visualization. Only needs to be done where we are very sure that the rhexis margins are visible. Now checking with the help of Sinskey hook that the nucleus is free. Yes, it's freely rotating. And now this phaco 1, and this is the sharp Mohanrajan chopper to keep the nucleus stable. So what I'm trying is to eat up little bit of the epinucleus, and then I decided to make a trench or a crater. And the settings were 180 and the power was high, 60 to 70%. The patient was moving a little, so we waited for him to stabilize. And this trenching needs to be deeper in the central part. So we need to eat up as much the hard nucleus in the central part as much we can, to make the later vertical chopping easier. Peripheral chopping is also a good option, but in this the pupil was not fully dilated. So KP sir, your suggestion or comments on peripheral chopping? When to go for?
No, actually, each person has his own technique. If you have practiced a particular technique, I think you can probably operate most of the cataracts using that technique. It's more, it's more for the beginners to actually have a confusion about which technique. So there are people who actually do in situ chopping itself, people who come from the equator, people who do stop and chop, people who do direct chop. So I think each technique has its own advantage and disadvantage. I think it's your familiarity and what equipments you have. You should have the right chopper for a particular technique. So that's the only thing. So there is multifactorial.
Yeah. So now phaco 2, the power setting is 60.
What is your phaco machine, Arvind?
Phaco machine I will tell you later on, because right, and this is in the mid bevel sort of thing. So this technique keeps the endothelial cell count at a minimum level, and now I'm able to achieve a full thickness crack. Right, you can see we have 2 heminucleus now. And now I'm using the terminator chopper, because the pupil is not dilated and it has a blunt olive tip. Right, so this is, I prefer to do for peripheral chopping. So now I can use it. So it's only the superficial impalement of the heminucleus. Under direct visualization and under the endocapsular margin, you can see it cracks very easy. This is the terminator chopper developed by Dr. Rajendra Prasad. Again, I'm trying to divide all these heminuclei into smaller pieces. And you can see now this phaco tip is less exposed. So this is high vacuum setting, step down phaco, starting from 400. We need to keep our steps, all this in the central region to avoid unnecessarily ECD loss. So almost half of the this nucleus is gone. Then first removing the chopper and then keeping phaco 1 on. Again pushing the 2% viscoelastic towards the cornea. Again bevel is down to prevent unnecessarily endothelial cell loss. I'm using the terminator chopper. Its tip is blunt to avoid any PCR or nick in the capsular access margin. So now in the last piece, this chunk, black brown, there was no followability. So I stopped. Suspecting PCR, so I need to check it. Pushing 2% viscoelastic, there is no PCR. So I went ahead. Because there is no cortex in such type of cases, so no second hand. So we need to be very cautious. And sometimes I put the IOL first and then remove the last piece. Little bit surge was there. So the whole nucleus was emulsified eventually. And now removing the cortex. And now the implantation of the autofocus pro IOL. So this is how it looks, 13 millimeter IOL with L-shaped haptic design. It's not the modified C loop. And the trailing haptic needs to be over the optic. And it goes very easily with 2.6 millimeter incision. Very slow, gentle unfolding. Trailing haptic needs to be dialed in the back. Removing of the viscoelastic material. Subconjunctival Genta DEXA and closure of the wound. So first day, 6x6 part, intermediate was I6, N6, and this excellent depth of focus the very first day. All the patients with clear cornea and healthy macula in diabetics are fit for this IOL. Autofocus Pro IOL has a great modulation transfer factor of 70%. Like a bullet train after binocular implantation, the average reading speed was more than 200 words per minute. Autofocus Pro IOL is the best choice for children as they need only monofocal spectacles for their myopia, but no progressive spectacles found. In a study of over 5,000 cases, in most cases, best corrected visual acuity was 6/9 or better if macula was healthy. Near vision was unaided N6 at 10 to 14 inch and computer vision was excellent from 2 feet to 4 feet distance. Easy vision threading in low light and after bilateral surgery was easily done. Almost there is no positive dysphotopsia, no glare, no halos, vision and no photic phenomena, so it is an IOL of choice in night drivers also. In conclusion, Autofocus Pro is an ideal rimless and non-premium IOL with no negative dysphotopsia, halos, glare, progressive polyfocal pupillar independent TCRL, correcting all types of vision and fit for night drivers with crisp and clear vision. These are my acknowledgements. Thank you so very much. So now coming to the machine, so that day means...
No, I have something for the IOL.
Yeah.
So how will you treat the astigmatic patients with this IOL? Do you have anything like a toric IOL in this?
Toric IOL is about to come within 3 months. That will be out.
So
Yeah.
you are here. Okay.
Sorry? Yeah, there are 2 holes, sir. There are 2 holes. And the viscoelastic also comes out through those holes. So the IOP surge is not seen. And now coming to the machine, Dr. Sharath asked me, so a day prior, my this Jais Quatera, it stopped working. Then I called Dr. LVK Raju and he sent me this Appasamy Galaxy machine. So I operated this case with Appasamy Galaxy.
Sir, have you experience with one eye autofocus and other eye?
Yes, we can have. We can have.
Multifocal or EDOF?
Yeah, we can go. We had implanted a lot of patients. In other eye, there is EDOF or monofocal or trifocal.
They are comfortable like?
Yeah. They are saying remove that other IOL and put this IOL.
Sir?
Yeah, it needs, both the holes needs to be in the superior depth. It's 200 micron, the 2 holes. So viscoelastic also comes out. Yeah, Hilon comes. Yeah. That's there. Yeah. Just like the phakic IOLs, no? They have 3 holes now. So they take care of that thing. Yeah. Any question? I'm happy to take.
Is there any complications related to, like some patient is actually complaining to difficulty to see in the very dim light or very close objects?
Yes, a very pertinent question. So all these refractive and diffractive zones are there in the premium IOLs. So there is a lot of interfered diffraction and there is very low modulation transfer function of 30 to 40% in the bifocals as well as the trifocal. But this IOL has very high 70% modulation transfer function, and as it's just a monofocal, it's the gradient refractive index is there, so it's a progressive. It's just like my progressive glasses, right? So there are no zones, refractive or diffractive zones. So there is no halos, glare, and there is no interference diffraction. Even for the diabetic patients, when we are doing laser later on, so there is no interference diffraction.
So this lens?
So
the angle kappa has no, it's pupillary independent, a fully pupillary independent IOL. The angle kappa more than 0.7, high hypermetrope, 27, 28 diopter, we are implanting it. In the central 0.9 millimeter, all the 3 zones are there. It's pupillary independent.
No, the question is, what she is asking is, you have to put it horizontally perfect in position.
Yeah.
How do you do that is the question, am I right?
The 2 holes needs to be in the superior part, as simple as it. And the serrated zigzag haptic is there, L-shaped. So it has the best rotational stability as compared to any other IOL. You will ask why, how it is happening? Because in all the premium IOL or the modified C loop, only a part. Yeah. Yeah, I'm answering that question only. Please, please listen to me, then you can ask the next question. So in the modified C loop design, only a part of that C loop is touching the capsular fornix, right? But this is a modified L-shaped zigzag serrated outer edges. So whole 6 millimeter of the haptic is in contact with the capsular fornix. That gives us an excellent rotational stability. Sorry? Yeah, no rotation, sir. No rotation. I myself have implanted in thousands, so there is no rotation. Not a single patient, and not a single patient more than 51,000 IOL implantation in India. Not a single patient is complaining of negative dysphotopsia.
No, we are talking about the rotation. No, I mean, she's asking, what if the lens moves up or down? What if lens moves up, the near segment comes to the pupil? Or what if the lens descends down? There's a sunset syndrome, what happens?
Okay, so we can do a WhatsApp small sphincterotomy we can do in the either in the superior part or in the inferior part. That works wonder. Yes, Katriya sir.
Yeah. Ma'am, if due to the capsular contracture, if let us say your axis is decentered, what we advise is that you do a YAG cut of the capsule wherever it is trying to decenter the lens after about 20 days or so. Just make one YAG shot or two YAG shots on the border of the capsule. But if it has gone down a little more, we can do a YAG iridotomy after a month or so. Just make a small cut in the sphincter at 6 o'clock position. But in our more than 51,000 cases implanted, if the axis is 5.5 and if the IOL is in the bag and you have placed it fairly well horizontal, it's not even necessary to have it absolute horizontal. It could be 20 degrees this way or it could be 20 degrees this way. It doesn't make any difference practically. So if the IOL is in the center and on table, whatever position, after 2 years also it will be in the same position, because the loop design is having knuckles like our fist knuckles, so they get engaged with the capsule fornix. The rotational stability is absolute.
Even if there is a rotation, suppose hypothetically, the quality of vision does not suffer, only the depth of focus suffers. What you saw is there, that is there almost in 90% of the cases. I mean, my practice, we do depth of focus of every patient, whether it is this multifocal or other multifocal. What depth of focus this lens gives, probably no lens at present giving that. And
thank you so very much. Thank you.
Yeah, here Dr. Ramesh Shah is here, and he'll be talking about both the astigmatism also in the same pro surgery, autofocus pro surgery.
the audio is your people. Can you start the video, please?
Some people.
Audio नहीं है. No, sir. I always do Rexis marking, about 5.5 millimeter in all the cases. This will help me to direct my capsular axis over the marking of the Rexis marking. This is a very unique blade. I call this blade as an aspheric blade because the tip of this is different from the rest of the blade. It has got a slightly slope exactly at the tip, which makes it so sharp that one of our staff nurse, when somebody was operating, she did not see, and they cut one of the fingers, and she developed a the injury to the nerve, and now her finger is like this. It is so sharp. This comes from money. I have no financial interest. This recording is done with our video glow system. One more thing which I want to show you. This is the blade which I am talking. It's an arrow. The other blade which is making the main incision is also a aspheric blade. Again, the terminal cutting portion is at different level than the rest of the blade, which makes it very sharp. This is the blade. If you see, the terminal portion, both the sides cutting is much thinner than the center one. And that's why it goes like a muska. You don't need to do all these things. And that's why it induces practically zero cylinder. This is lignocaine, oculan. I always use methyl cellulose. For all the people, junior surgeons, methyl cellulose is very important when you're doing a Rexis, because when you use a methyl cellulose, the mobility of the needle is so smooth that in one stroke you can complete the Rexis. This is another important step which you see. The bend of the needle should be at least 60 degree. It should never be 90 degree, because when you do it 90 degree, you cannot see the tip. What you see is the bend, and then your direction may not be accurate. So always bend the needle at 60 degree, and it should be half of the bevel size. Whatever the bevel you see, it should be at least half of it, not less than that. Because if you do it less than that, your portion which is there near the wound will press, and the wound leak will occur. The wound leak will occur. So you need to do a 60 degree of bend and at least 50% of the bevel portion. This is another needle holder, which is a very special needle holder. It should not have a single serration. This needle holder is kept only for bending the needle. It should not be used for any suture tying or anything, and this should be kept separate. It is quite sturdy, so bending of needle will be acute and not a curved one. These are the small points which will make your Rexis perfect. See this 60 degree bend, and bend the needle somewhere near the junction of the metal portion and the plastic portion, so that you have enough length to go up to 6 o'clock position. I always use the main port because we have a distance to maneuver. If you are going from a very small port, it is quite difficult to move 360 degree. So most of the residents which I have, they are trained with this very small incision. I request all of you, try even the larger incision Rexis, and whichever you like it, you continue. So in single stroke, you will be able to finish the Rexis. See the mobility of the needle in presence of methyl cellulose, not hyaluronic acid. If you want to use hyaluronic acid to protect your endothelium or chondroitin sulfate, first you put methyl cellulose, over which you put the hyaluronic acid. So there will be a sandwich of two, but that will help you to do the Rexis very smoothly. You do the hydrodissection in 3 or 4 zones, so that your separation of underlying cortex is quite significant, which will help you to remove them subsequently. Again, a methyl cellulose. You see the color balance of this picture because it has got a special software which increases the red portion, the red bright light more as compared to the blue and the violet light. Again, there is one more thing which I want to tell the youngsters. The exposed portion of the tip, it should be at least 2 to 3 millimeter. Should not be less. If you have a less, then you are not able to grip them well. So remember, do not keep only a very small portion exposed of the metal tip. Let it be at least 2 or 3 millimeter. In this tip, there is a groove there. You should keep your sleeve beyond that. This will help you to grip it. Now I move the right hand, the chopper more than the phaco tip. Whenever you are cracking the nucleus, always move the chopper more than the nucleus. If you do that, your cracking of the nucleus is almost always there, full thickness. Make the multiple pieces like a pizza. If you want, you can remove one by one and then crack them. This is relatively a soft cataract. See, I hardly move the phaco hand. I always move my left hand. Hold it, bring it in the center. I use Stellaris machine. I have a mostly fixed parameters. 90 is my height of the portal. I have 30 or 40 is my phaco power and 250 is my aspiration. This is my fix unless there is a dense brown cataract. Otherwise, I do with them all the cases. This Stellaris machine, you don't need to follow the nucleus. The nucleus follows the phaco. This is one of the fastest machine I have seen. We are Venturi people. Myself, Dr. Katriya, most of us are Venturi people. Just come out of it. I use coaxial. I rarely use bimanual. This metal tip which you have here, I had a silicone tube. I had purchased few of them, all of them are torn, so I don't have that. But that silicone tip was very good, so that your PC rand, even if you are touching them, rarely occurs. Do not move in the periphery. Once you catch it, bring it in the center with the force. It will help you to separate the cortex from the peripheral region also. See, nice rexis. We don't need a femto for creating a good rexis. Again, with the head of jet of fluid, you can remove the whatever small amount of cortical matter which is attached to the posterior capsule. If I had a silicone sleeve, I would have removed this with the silicone sleeve. Silicone tip, not the sleeve. We have two varieties of autofocus flow. One is hydrophobic, other one is hydrophilic. Dr. Moore has already given the details of it. I am putting an hydrophobic lens. It's a preloaded lens. It has got a push and screw mechanism, both of them, whichever you like it. This is how it is. This is the lens which is preloaded. I have already put the viscoelastic. Here I use hyaluronic acid 14% so that I can remove the things easily. It gets locked. You get a click sound also. You can put extra viscoelastic. Here you can see the movement of the lens inside the cartridge system. The lens comes out like this. It is extremely easy to implant this hydrophobic lens. I do 10 cases a day. I have done about 4,500 in 1 year, 1.5 years. Autofocus Pro. In my practice, only one lens. If they like it, fine. If they don't like it, they can go. Now here you see, after inserting the lens halfway, I just don't do anything. The lens goes on its own. You don't have to push that thing. So that the trailing haptics will not get stuck into the silicone sleeve. You can hardly see any rings there, only 2 triangles are there. Now Chitra was asking me, how do you center this lens? Now if you see, this is the first Purkinje's image. For me, this is very important. And both this triangle has to meet at the first Purkinje's image. Regarding the displacement of the lens, if the lens gets displaced inferiorly, what Dr. Katriya said is you can make the small nick. If that does not occur, explain the patient and give the addition if required. Rotate the lens so that 2 holes are superiorly placed. Now you can see these 2 triangles. You can see that? These triangles are for the intermediate vision. The lower portion is for near. Recently, Dr. Dholakya, she has not yet come. She has started using this lens for a long time, but then she suggested very nice thing. If your angle kappa or alpha which is more than 0.7, she started putting lens vertically in such a way that these 2 triangles meet at exactly at the Purkinje's first image vertically, so that she puts little nasally and inferiorly. We are coming out with 4-loop lens also because some of the patients. One more thing which I want to tell you here. This is one line which you are seeing, no? The one line which is there, which is a stretch mark onto the posterior capsule. Do you see this? This is one thing which I am working on it. Both of us are working. We are coming out with something fantastic related to these lines. Probably it will take 6 months to come out of it. Something most unusual is expected to come out of it. And this is for all the lenses. So it took almost 7 to 8 minutes to finish this surgery. I love this cannula. Even Moria loves it. To remove whatever is remnant. Most of the new generations have never seen this instrument. You can see the Purkinje's image here. This is the one which is. Now when you move the lens, the first Purkinje's will not move. Rest of the lens, rest of the second one you hardly see. Now see this movie. This is the third one. See this mood. This is the third one. And the first and the third one, when you match with each other on the same axis, that is the place where your lens is placed properly. The highest angle kappa which I have done is 0.7. You see this is the first Purkinje's image and this is the second, and this you see these 2 triangles. So it is almost 12 minutes for the whole surgery. I have done slowly because I wanted to show and demonstrate this lens. You see this, the line which is straight. This is one which you are working on it. We will find out some best solution for all of us. I will show you the AK, astigmatic keratotomy. This is the patient with 1.25 cylinder. The steep axis I think is horizontal, 180 degree. No, I think it is not this. This is the one. This is the marker which is at 6 millimeter distance, diameter. This is 60 degree. The angle between the 2 arms is 60 degree. You just mark it horizontally. You can see these two markers. This is the SBS blade which I had when I was doing my RK. It's a dual blade. One end is complete cutting and the other one is only half cutting. This is a 60-degree marker. I was doing 3 cases of toric per day. After doing this procedure for last 1.5 years, we did about 1,500 cases. My number of toric lenses are reduced 3 per month. Now here you cut this at 6 millimeter and then again go back, so that whatever uncut portion is there will cut and you have a perfect square edge incision taken for astigmatisms. This is the blade which I am showing you. And the last portion which I am going to show you is how the moxifloxacillin looks inside the eye. Here you are using the moxifloxacillin. Switch off the light and you see the blue light. You can see the it's a fluorescent chemical, and you are able to see the moxifloxacillin inside the urine. This will ensure you that amount of moxifloxacillin uniformly spread inside the anterior chamber. With this, I thank all of you to listen to me and our autofocus pro.
There is some cyclorotation when the patient lies down. Cyclorotation of the eye when the patient lies down. And when he gets up again, there is some rotation. But we are here doing it.
You are talking of the cyclotorsion.
Cyclotorsion, yeah.
Cyclotorsion. To be very honest, I have not thought of this. Very honest. But the amount of cyclotorsion is not that significant as far as the IOL surgery. It might be very significant as far as the LASIK is concerned. Rotation, yes.
No, he is talking about the arcade keratotomy.
Arcade is not that accurate what you are talking.
Yeah, exactly.
It's a broad base. It's about 45 degrees. So even if 2 degrees here and there doesn't make much difference.
Cyclotorsion for toric IOLs is important. It's anywhere between 5 to 7 degrees in most people. So here, since it's a very long arc,
it's a arc.
It doesn't really matter.
It doesn't matter. What you said is correct, but I have not thought about this.
Instead of 2 holes, it is very difficult to place 2 holes very superiorly. One is maybe 5 degrees down or one maybe 5 degrees up. So instead of 2 holes, you make a hole at 12 o'clock position correctly. So if we can mark the marker with the 12 o'clock position and we'll keep the lens in the correct way like toric IOL.
That is a good suggestion.
Prevent the torsion.
The only thing, we also thought of keeping the 2 horizontal marking like a toric one. It's not that easy to move that lathe machine like this and that.
Yeah.
It is extremely difficult.
It is not
This
moving.
design, it took 2 years to...
When you are putting also the 2...
Instead of 2, we can put 1 at 12.
And single line, it is very impossible to everybody.
Agreed. We will probably think about it and put it. It has got 0.9 millimeter in the center. I repeat, 0.9 millimeter in the center has got 3 powers. Near, intermediate, distance. To create that kind of profile is not we want to create profile with 2 horizontal marking. We are not able to do it till today because those lathe. We got the 3 powers. With the lathe machines and the software which he created for that. And it is demonstrated onto the OPD scan. This is, I think is not shown now, but the previous we have shown that all the 3. And all the 3 powers. I'll tell you, there are few patients where we had failed to create this. And those are the unhappy patients. But the best part of is, this is the lens which is created by clinicians and evaluated by the clinicians on a proper machine. So we have a feedback which is very nice. Any unhappy patient, moment you put onto the OPD scan, you will find out something, that there is something wrong in the IOL, something is wrong with the angle kappa, we have missed it. It's not that there is one patient, charter accountant, where the lens was okay for 1 month and it got shifted to left. And he developed a serious negative dysphotopsia. The centration of most of the multifocal lens has to be very central. You cannot have a compromise. Then you have some amount of problem with it. But negative dysphotopsia is very, very rare, practically not there. Positives are also the lowest.
So thank you, Dr. Ramesh.
Thank you so much.
Let me go ahead with my presentation.
Yeah, we call upon Dr. Sharat Babu, is already there.
Yeah, I am Dr. Sharat. Now you have to, how many of you are doing multifocals or trifocals? Yeah, so this presentation will help you. So today I am going to talk about the IOL, which is from Hoya company, that is the geometric. The geometric trifocal is like any other trifocals what you have seen in market, but there are some differences which I will share my experience with you. It's a trifocal, the spherical aberration is corrected, it's a negative, so it will be on the positive side in the final spherical aberration, and it's tolerant to coma, and of course this got a toric IOL also. And the material is the same as the Clarion or other new generation IOLs, wherein it's very smooth and then goes inside and then fits exactly into the IOL. And it's glistening free, and it's a C loop and 13 mm size, and the optic as usual. And then the haptic is here you have to see the haptic is sandblasted. So like Katriya Towers has got those waves to prevent it for rotation. This IOL has got a sandblasted tip in the haptic which prevents the rotation. And it's a preloaded system. It smoothly goes through even 1.8 or 2 mm incision, and very smoothly it goes inside. And it has got two variants. One is the geometric and the other one is the geometric plus. And Hoya, as you know, it's a company with which play on optics, and they came out with these IOLs. Wherein they played with the amount of IOL entering into the eye. Usually trifocals, what happens is its maximum is 80 or 83% what they say, that the IOL or the light goes inside, whereas here it is almost 90% or even a little more than 90% which goes, and that's the key in this IOL. And of course the near vision addition is 3.5 and intermediate is 1.75, so the patient is very comfortable for distance, intermediate and near also. And it's, the main, the diffractive optics, there are about in the 3.2 mm. There are 8 diffractive rings and not more than that. That's why the patients, even the patients who drive in the night also, they don't feel this dysphotopsia, this phenomena, photic phenomena, they don't feel much when compared to other trifocal IOLs. And it's a preloaded and it's a very good system. And this two IOLs which I've been telling you, the geometric and geometric plus. So the addition is the same in both the IOLs, whereas one eye is designed in such a way, for distance the more light enters inside. The other IOL, it is like the near vision more light enters. So it is balanced in such a way that when both the IOLs are put one in each eye, both the distance and near vision, even in dim light, the vision is really good in these patients. And this is what I am talking about, the amount of light entering for distance, intermediate and near. And it has got 4 diffractive double rings, and it's a negative asphericity. And this is the optical size is 6 mm. And defocus curve, you can see both of them are really almost the same when you see, but night vision is much better when they are implanted in both eyes. And it's a pupil independent, and they have got the toric IOLs also, but when you say they've got up to the correction of 2.7, 2.6 diopters corneal plane, but when you want more, you need to go for the other IOLs. But most of the patients, they fit into this segment only. And this is, I'm showing you one patient by name Radha, which her name is not the real one. She came for a surgery, and this is what the A scan shows. The patient is being implanted with the toric IOL. You can see almost 1.82 diopters of astigmatism in this patient. And of course, I've got a variant, so on the variant also we recheck again. And whenever we select a patient, selection is the most important thing whenever you put a trifocal IOL. And she's a homemaker, that's what is been written when she came. But when you went into the details, she drives the children to the swimming in the night and then morning to the school also. So we thought this IOL will fit her. Nice. So this surgery I will show you. I always use a 2.4 blade from Appasamy. It's really good. All my surgeries I use Appasamy. I have a Alcan machine. And so the IOLs, this can go even through 1.8, but 2.2 mm is the desired for the phaco to do, but 2.4 is what recommended by Dr. Ramurthy. But when I started operating using 2.4 mm, I could see the results are really good. And here I have put some xylocaine inside, intraocular xylocaine. I'm waiting for a while. And then I use only methyl cellulose 2%. So 2% methyl cellulose inside. So I don't use any other blades for the side port. I use a simple 21 gauge needle to enter on either side, through which a 26 needle can go very easily inside. So on either side, I enter. The cystotome, my nurse is really good. She does all that. So the important thing in any trifocal or any toric IOL is your CCC has to cover the whole of the optic. That is the most important thing. The reason is you wanted the IOL to be centered very well, and it should remain the same for a long time or forever. This is the other eye I am implanting, so I am doing a little bit slow. So after that I do a hydrodissection. Do it posteriorly and then separate the anterior capsule also on either, and all the way around. I got the Centurion phaco, so I think they put it in slow motion. Our IT guy. So for this patient, I use 70% of the power. The whole video came in 5 minutes, so I think has made it slow. That's what I'm seeing now. I split it up into two. I don't know. It's messed up. I know. It's in slow motion.
Hello, Sharath.
Yeah.
You better tell, otherwise people will think you should do like that only, probably. Very slowly.
Knowing Sharath, they will not believe this.
I know. But anyway, so you catch hold of the cataract, take it away. Should I fast forward it? Yeah. I think so. I think the option is not there. Yeah, they made it 20 minutes.
It's your mistake to give 20 minutes. Should I give them 2 minutes?
Yeah, I know. Yeah, I know. I think I don't have a choice, I think. Oh my God. It's going to first again. Anyway. We don't have a fast forward option, is it? Yeah? We checked it so times, finally it got messed up. In IT guys, can you fast forward this? Any chance you have? Can you do that? No, again this can't go to the... Huh. Yeah, I'll just show you the IOL, how it is. This is real in slow motion. So after putting the IOL, because it's a Varian machine, so I turn it around and then put it in such a way that it goes straight away and then lies there. So we had a study of these IOLs, all the toric IOLs and then even the geometric. So they are placed so well and the rotation stability is less than 4 degrees. This is what our observation is after implanting so many of these IOLs. So the placement is exactly perfect in that. So the post-operative vision, after the first post-operative, what we checked is the autorefractometer reading only. Most of the multifocal IOLs, what we do is, once we see the autorefractometer reading post-operatively, once we think that the patient is good, the reading is good, we never see the vision for these patients. Because you keep on seeing the vision, they keep on asking so many questions. The only thing is we make them happy, both for distance and near. And if any changes in the refraction on the first eye, we modulate in such a way that the second eye is also operated or change the power a little way here and there and then do the surgery. So thank you very much. Any questions?
Sir, what is the difference between this plus and other multifocals add value?
No, add value is the same for both these IOLs, 1.75 for intermediate and 3.5 for near. So both of them are good, but the amount of light which enters inside for near vision is more in this. So in the dim light or in the dark light, the vision is much better because the more of the light enters inside.
Light distribution is for different.
Light distribution is different.
So thank you, Dr. Sharat. Very
Yeah.
well.
Probably I'll share the original one after a while. Yeah.
Now we call upon Dr. Rishi Swarup to demonstrate the natural lens from the care group. Another new IOL which is very promising. Now, one question, Dr. Sharat Babu. What about bilateral implants? Like, do you always want to assess the effectiveness after a bilateral implant, or you also see the patient after one surgery and patient can make conclusions?
No, we operate the first eye and the next day we see the post-operative refraction. And then when the patient wants to come back again for the second eye surgery, probably we operate the second after 3 days. So when they come back after 3 or 4 days, we again check the refractometer reading and then accordingly we change the IOL. If there is any change we need, like distance or near, we modulate accordingly the IOL power.
This doesn't work. No, sir, that's normal.
Yours is normal speed or fast forward?
Normal speed. I'm not such a fast surgeon that I have to slow down.
Dr. Rakesh, what is your choice like in making a patient spectacle independent? What is your choice of, not necessarily the brands, the kind of, the choose the modality of lenses or different kinds of lenses that you have?
Sir, any lens, any company can use. There's no actually.
Do you do monovision, you do EDOFs, you do trifocals? What is your choice?
My choice of trifocal is, I think, best for the other thing.
You started?
Hello.
Yeah, Rishi.
At the outset, yeah, I'll start. Sound will come later. At the outset, I'd like to thank Care Group for sponsoring this live surgery session, this particular segment. And so what we are demonstrating in this particular near live surgery demonstration is this particular technology of Z8 femtosecond laser, which is a femtosecond laser which can be used for cataract, lenticular extraction and for creating LASIK flaps. In this case, I'll demonstrate the femtocataract, and then we'll be implanting the lens called Naturo from Care Group, which is a new lens which they've launched, which they say is a complete range of vision. This was in fact the first implantation that I've done, so I don't have too much experience with it, but it was, the patient did get a very good outcome. After that I implanted another 2 patients who were quite happy, and we'll share. So these are the parameters for the femtosecond laser. So we've, I always try to choose the main incision along the steep axis, and then 2 paracentesis on both sides. I like to go with 4 cuts in the 4 radial cuts in the nucleus. I don't really use the rings, etc. And I create the incisions always using the femtosecond laser itself. Unlike many other platforms, the corneal incisions of the Zimmer platform are actually very, very good. Now this is a very unique thing about the Zimmer, is that the machine is very, very small and portable. So this one point I want to stress here, we are this is very important. Before you start, I think none of the surgeons talked about it, but it's very important. Please check everything. You check the parameters, check the lens, and this particular step, check the eye, check the patient. A timeout is something all of us should do for all our surgeries, not just for cataract surgery. Timeout means you stop everything and check that everything is all right, the lens is correct, and just recheck everything before you proceed for any patient. Now after we do that, we basically, that's the small machine, you know, it fits into a lift, it's so tiny, and the whole femtosecond laser arm is portable. You can directly lift it and dock it on the patient's eye, so it makes it very easy. So I have already done the docking on the patient's eye. It has a patient interface which holds the eye with suction, and you can see the picture of the eye there, and it's showing the diameter of the rexus, which is 5.1 millimeters is what I choose. I am talking thinking that the video will finally have audio, but obviously it doesn't have audio. Yeah, so it has an inbuilt OCT also in that little handpiece which I am holding. So it checks whether the lens scan is appropriate. Accordingly, it automatically detects the borders of the lens and has a safety margin depending on what you prefer on the posterior aspect from the posterior capsule. So now we are proceeding with the main laser. First it cuts the nucleus first, then cuts the rexus, and then finally creates the rexus, the corneal incisions. So it goes from back to front. Okay, so you can see now that the white lines are becoming red, so that's the nuclear cuts which are happening. You can see it's exactly corresponding with the nucleus of the lens on the OCT there. And once that is over, we are moving now to the capsulotomy. Now that has started. You can see the green is becoming yellow. You can see the cuts of the previous. So every time one step is over, it captures an image and you can see it on the screen. So the cuts, you can see those 4 cuts. Now the rexus is over, you'll see bubbles appearing on the eye image. You see those bubbles? That's where the bubbles have broken through the rexus cut. And now finally we are making the clear corneal incisions, which is the main incision, and which is in purple, and the 2 side ports in blue and green, as you can see. So that's all the machine is. It's so portable. So that's fired. We don't drape the patient initially if the pupil is of good size. I do the first laser in a semi-sterile kind of a fashion, and then after that we clean and drape the eye and proceed with the femtosecond laser. So this is just some little information. Audio please. Information about the lens itself. So this is care group people have put this in the video. Can we have the audio? Audio please. It's connected.
The light from each zone is directed.
I'll just start that again. Yeah.
Edgeless phase matching technology transcends the boundaries of refractive and diffractive optics. In refractive optics, multifocality is achieved by different regions of the lens having different curvatures. The light from each zone is directed to a single focus based on the vergence of the zone. All of the light energy from a particular zone is directed to a specific focus. At the focal points, light rays do not bear any specific phase correlation. There is significant light loss and side effects from stray light at the zone transitions. These lenses are always pupil dependent because exposure of a particular zone of the lens through an aperture leads to a light distribution that is extremely skewed in favor of a particular focus. Diffractive optics has managed to address the perils of refractive multifocals by utilizing interference. These lenses have a diffractive profile imposed on the curvature of a monofocal lens. From each zone, the light gets split into different orders of diffraction. Pupil independence is achieved as each zone can contribute light to at least 2 different foci. From each zone, the light energy that reaches a particular focus interferes constructively to achieve a higher contrast. However, there is significant unaccounted light loss, which results in waxy vision, poor contrast, and photophenomena. This is because light energy falling on a portion of the lens surface forming edges gets wasted. Various modifications of the diffractive profiles are focused on modifying these edges or reducing their heights and numbers in order to reduce the adverse visual effects. Edgeless phase matching technology features the LMAX profile, which utilizes 100% of the lens surface to shift and match the phase of light energy incident on the surface in order to achieve several foci and subfoci. The wasteful surface is completely eliminated. Each zone of the LMAX profile splits the light energy to distribute it to at least 3 foci and subfoci. Light waves incident at these foci interfere constructively to achieve enhanced contrast sensitivity. Desired light energy distribution or pupil independence is achieved while eliminating unaccounted wastage of light and resulting photic phenomena. Edgeless phase matching technology thus achieves the most physiological, natural quality vision, natural panfocal vision.
So that's the mechanism of the lens. So I'm just rechecking again the power of the lens, etc. before we start. So it's a 20.5 diopter lens. Okay, so I always like to stain the incisions and stain the capsule even in femtosecond laser, because even though I have not had that tags of attachment, it can happen sometimes that you have a tag, and if you don't notice it, sometimes that tag can extend to the periphery. So I always like to stain and make sure that the capsule is free floating. I think 99.9% it will be free floating. In all the cases that I have done, I think one case the rexis had a tag, otherwise almost all of them will have a free floating rexis with this particular machine. Okay, so you open the incisions using a Sinskey hook, and you can almost always open it very easily. You don't really have to put too much effort. Here you can see the rexis is free floating. I am using a micro rexis forceps, and you can see it's completely free. So almost always it's like that. It's a good idea to stain even the outside of the eye with trypan blue to identify the points where the main incision and the paracentesis have been made. You can see that I have applied trypan blue here. The suction where it has been applied, you can see that is marked out, and the sides of the entry are marked out, so you don't scratch the cornea looking for the port. Sometimes if the air disappears from the femtosecond laser cut site, you will not see it. Now you can see very clearly these incisions there. These are the incisions created by the femtosecond laser. So in this case, the lens is actually very soft. So probably they don't have too much value in a soft lens, but in a very hard cataract like grade 3 or grade 4, I think they have a great value, because they really aid in creating the cleavage plane and significantly reduce the amount of phaco energy that you might need to use to crack the nucleus into pieces. Okay, so now I'm just introducing the phaco handpiece. This is the Centurion phaco handpiece that I put in, and this is the balance tip. This tip is actually very, very nice, especially for harder cataracts. It really cuts the nucleus very, very comfortably, and I use the IP technology in the Centurion. You can see very easily I could just crack it into that old cleavage plane, because there was already a cut there. So you don't even need to create a trench. Actually, you can just hold the central part with the phaco, just bury it in, and then just introduce. I always use a sharp chopper, even if it's a soft cataract. And this is Dr. Mohan Rajan's chopper. I think it's the best invention that he has done. It's really fabulous, and it has made my life very, very easy in hard cataracts. But I use it even for soft. I think soft cataracts, if you use a thin chopper, it doesn't cheese wire, and if you create like a wide trench and all, it will tend to cheese wire. You can see it's opening up very easily. So sometimes soft cataracts do tend to cheese wire. So in this case, it wasn't rotating very easily. So I'm putting in some viscoelastic and then turning the nucleus using the viscocannula itself. So I use the viscocannula very liberally during my phacos. Sometimes if the nucleus is soft, I will put visco underneath the nucleus and then prolapse the nuclear or the epinuclear bits with the Sinskey hook. If it's a very hard cataract and the posterior plate is not cracked, I try to insinuate some viscoelastic behind the posterior plate and then lift up the center with the Sinskey hook. Of course, in this case, because it's a soft cataract, none of that will be required. So in this particular case, it's cheese wiring a little bit because the cataract is really soft, but because we have a cleavage plane, it opens up exactly along the cleavage plane, as you could see. So this is the beauty about this particular phaco machine. You don't really need a second instrument. The pieces just come to the phaco tip, and the fluidics are fabulous. So once you've made the pieces, you don't really need a second instrument. So there's no second port through which the fluid is going out, and the chamber remains super stable. And as you can see, I don't like to direct the phaco energy towards the cornea, so I always keep the phaco bevel either oblique or sidewards, or even sometimes pointing towards the posterior capsule. I am quite confident of the machine, and the surge is very minimal, so I think it's quite safe. So you can see that the nucleus is very easily come out now. This is a totally unedited video, so you'll have to bear with me. I'm recentering the microscope, etc. now. So the idea of the near life surgery is that you see it like a life surgery without any editing. So the femtosecond part, the IOL presentation and the unedited surgery totally will come to under 20 minutes. So you can see that I'm using a bimanual IA, and of course one can use a coaxial as well, and principle is to go underneath the rexus. In a femtosecond laser, it cuts the edge of the cortex also, so you don't really have a central cortex leaflet to grasp centrally, so you have to go a little underneath the rexus, grasp the anterior cortex and pull it in. And I'm just changing hands to go to the other side. This is a very nice bimanual irrigation aspiration cannula from Epsilon, which I like to use. It has a very short irrigation handle, and it is much wider in bow, so there is no surge, and it gives you a very nice stable anterior chamber. And the irrigation handpiece is not unnecessarily long. You don't need it to be long. You just need it to come into the anterior chamber, so it works very well. And the aspiration cannula is sandblasted. So that's pretty much done now. We'll just put in the viscoelastic and implant the lens. So the lens is, I would say, in terms of shape, it's similar to the Rayner double loop or their RYCF, SQ-RYCF model. It looks very similar, but it's got more advanced optics. You can see those little hint of multiple rings there, but they're not really rings, or so the company claims. And this goes in through a 2.2 millimeter incision, wound assisted, of course. So you use a regular butterfly cartridge. Again, just showing you the lens. So whenever you use this double butterfly cartridge, make sure the optic edges are tucked under the grooves, and then the haptics don't really need to overlap the optic. You just need to tuck them under on either side, and when you close, you'll get a click, and then you load it onto the cartridge from the. It's a front loading cartridge. I think they have a very good cartridge and injector system. You always check that the lens is moving freely. If you get resistance, that means the lens is caught somewhere in the cartridge. Okay, and I also like to withdraw and see, make sure that the lens is also coming back when I withdraw. Okay, now just a wound assisted insertion. You should put the tip firmly against the wound so that the wound becomes part of your cartridge or tunnel. The tunnel becomes part of your cartridge or insertion system. Okay, so the first haptic is gone into the bag, second haptic is in the AC. And one can use the Sinski hook and easily dial it into the bag, and the lens is in place now. So this is a hydrophilic lens. I think the company has plans to bring it in their hydrophobic platform as well. They always launch their new lenses first in the hydrophilic platform and then move them onto the hydrophobic. And then essentially through the two side ports we are doing the irrigation aspiration. So see how beautifully the lens is centered. You can see the rexus margin perfectly overlapping the optic symmetrically. And I think this is where femtosecond laser really has an edge. One is difficult cataracts and one is when you're doing premium lenses. So you want the lens to be perfectly centered for the patient's visual axis, and this technology certainly gives you that edge for multifocals, EDOF, and even for toric lenses. You want toric multifocals, you want a perfectly centered, well aligned lens. And now we even have specific lenses which are made for femtosecond laser. There's a company called, there's a lens called Femtis which clips onto the rexus, and that needs to be perfectly centered, and that is made to be used with a femtosecond laser. So I think that's also something exciting, and I hope the Indian companies can also come out with something similar. Okay, so that's about it. As you notice, I went under the IOL also to remove any viscoelastic which might be trapped. Sometimes you'll have a little bit of loose lens material as well there. So you can easily do that quite safely as well. So that's the end of surgery. We're just going to just hydrate the ports. So when you hydrate, just remember you want to point the hydrocannula anteriorly towards the epithelium. Don't point it towards the endothelium, otherwise you can detach the desmoids if you're not careful, especially if you used blunt tipped instruments. Okay, so in this case, on either side of the wound, and then the inner lip, but the anterior, point the cannula anteriorly. Don't use too much of force, gentle force, just enough to create that little bit of hydration and whitening of the tissue. That's it. Check the pressure. You don't want to overfill the anterior chamber and make the eye tight. Thank you.
Dr. Rishi, even I use these IOLs.
Yes.
But this looks exactly like the Rayner refractive multifocal.
That's what I thought, and I told the company guys, but they claim that these patients don't have halos. The 3 patients I used it in, none of them have halos, and they seem to be happy, but my N is too small right now to make. I'm not sure, 4 or 5. Yeah, looks like 5. They're not, that's what I think so, but they claim that they're not going to be there, so we'll see. Maybe if the K group guys are here, they can answer.
Even they don't know.
But the 3 patients who I did, I asked them.
It's a Rayner model, that's
they're
what
okay.
I feel.
So far they're okay.
Same. Rayner refractive IOL, and these are the same.
Thank you.
Superior means 2 things you have to ask again. The photic phenomena, how are they in these patients while driving? Do they experience any?
I think we'll have to wait and find out, but the company certainly claims that they don't have any of these photic phenomena, but we have to take this with a pinch of salt.
In my experience, they don't have any problem because I implanted almost 17 lenses.
Okay, that's good.
And then, most of the patients are really doing good, but I'm scared because I don't know the long-term results, how they are, the posterior capsule thickening and all that.
Right.
So once it takes care of, I think this lens, I think everything is shifting towards refractive again, from diffractive to refractive.
Back to refractive.
So it's very difficult to answer that question, which is a better IOL, and comparing them, because it's very difficult unless we are seeing it. The patient is seeing, and we are trying to get some information from the patient. The patient's opinions are very subjective. It depends on so many factors: their requirements, their aspirations, how much money they have paid, and there are what is the eye as such other than the IOL surgery. So it's a very difficult thing to ask. The only thing is we need to look at some objective parameters. Halos, rings, it's again a subjective thing. A lot of patients, unless you tell them, they don't complain.
Yeah.
If the patient says halos and rings, I say very good, the multifocality is working.
It's working.
They must be having a very good near vision also. Most those patients who complain of halos will have a good near vision.
These patients, it's all about expectation management.
And it's about patients being happy. I think making a patient happy is not your problem. They are happy for their own reasons. They are unhappy for their own reasons. IOL is a very small part of their life. I think that is the message.
Thank you.
I think the chairman scientific committee looking at us to wind up the session. Thank you so much, TOS, for the opportunity. I'll leave the stage for the next session. Thank you very much. Dr. Altaf Akbar. Dr. Ramesh Ayala. Dr. Okay. Dr. Bharat, yeah. This is it, no? Yeah. Hello, sir. Sandeep Reddy, yeah. Yeah, Dr. Sandeep Reddy.
Shall we start, sir?
He'll speak on extended range without compromising with Raven EMV lens.
Good afternoon, everybody. I'm Sandeep Reddy. I'm from Andhra. I'm a cataract and vitreoretinal surgeon. Basically, my roots are from Hyderabad because I'm a student of Sarojini Eye Hospital. So today I'll be talking about an extended depth of focus lens from Rayner, which is a hydrophilic platform. And I just want to remove few myths that what people have regarding the hydrophilic IOLs. So as you all know, cataract surgery has become more of a refractive surgery. So coming to basic introduction of a hydrophilic lens is actually made in a dry state, and once it is supplied in water, it actually swells. So that is the basic meaning of a hydrophilic lens. While a hydrophobic lens is made dry and it is applied dry, so the lens does not swell. So what happens when the lens swells? The square edge that is made is lost. So that is the reason why hydrophilic lenses do not have a very good square edge, which results in a lot of PCOs. And there is a bad reputation that these lenses change color, opacify or calcify over a period of time, which actually these lenses don't, the recent lenses don't really have this kind of a problem. So overall, why hydrophilic lenses are very important is because hydrophilic IOLs have the highest UVL biocompatibility because of its water sustaining nature. While your hydrophobic IOLs are not really very much UVL biocompatible lenses. They are supposed to be implanted perfectly inside the rexus. So if there is any kind of an exposure of hydrophobic IOLs to the uveal tissue, it causes a lot of uveitis, things like that. But while a hydrophilic lens, even when exposed to uveal tissue, they don't cause really too much of reactions. So these lenses have when you inject hydrophilic IOLs, they have a very smooth recovery, and as you know, hydrophilic lenses, they don't stick to the posterior capsule, which helps us to do Nd:YAG laser very much easily, not damaging the optic. And the dysphotopsias are much lesser in hydrophilic IOLs in comparison to hydrophobic IOLs. So hydrophilic IOLs have very good handling characteristics because it's very predictable, they open very easily, and they are not temperature dependent. Actually, when you implant a hydrophobic IOLs under very cold temperatures, they really don't unfold very well. It takes a lot of time, while the hydrophilic lenses, they don't really get affected by the temperature. And the silicone oil also does not adhere to the hydrophilic IOLs, and the adherence is much more common in hydrophobic IOLs. So what are the basic disadvantages is, the PCO rates are obviously much higher in comparison to hydrophobic IOLs because of the non-sticky nature of these lenses and lack of the square edge. So these are the two important characteristics that is lost in these lenses, which results in higher PCO. And chances of calcification is, I haven't never seen a hydrophilic IOL getting calcified, because these newer lenses have a better material, they don't calcify over a period of time. See, then a lot of us can say, what is the problem in doing a yak capsulotomy? Why is that it's so important that you have to prevent PCO? Why is it that we talk so much about preventing PCO? See, whenever you open the posterior capsule, it actually, the aqueous actually starts washing out the hyaluronic acid from the vitreous body cavity. So because of the loss of hyaluronic acid, the entire vitreous cavity collapses and can cause an acute PVD, can result in retinal tears and retinal detachments post yak capsulotomy. This is the main reason why you want to prevent a yak capsulotomy in a patient. So when you actually look at patients with diabetic retinopathy or vein occlusions, it is well known that collagen cross-linking happens in the vitreous cavity, and the normal adhesions of the vitreous to the retina, they become very strong. And you actually observe PVD can never happen in most of the diabetics, especially in cases with diabetic retinopathy. Okay? And in cases where the patient has already undergone a vitrectomy, obviously there is no vitreous. Even if you open the posterior capsule, there is no chance of retinal detachment or retinal tears to happen. So in such cases, there is no problem for me doing a yak capsulotomy. So for me, the preferred IOL in such cases is more of a hydrophilic IOL rather than a hydrophobic IOL, because in complicated eyes, I want to implant a very good biocompatible material rather than a non-biocompatible material like a hydrophobic IOLs. So Rayner has developed a very good hydrophilic acrylic material, which is it's a copolymer of hydrophilic and hydrophobic material, and it has got a good water content of 18%, which makes it a good biocompatible material. So with the exceptional high UVL biocompatibility, I feel these lenses are very good, especially to implant in uveitic eyes in diabetic patients. It is also good to in pediatric eyes, and though the PCO rates are seen in these eyes. I also use these eyes in cases with phacotrabeculectomies, and obviously these lenses are very predictable and very good handling characteristic, because the way they open is very predictable. And even in silicon field eyes, I generally use these lenses. These are some of the pictures which I have taken from my patients. So this is one of the yellow lenses from the premium IOL. It's a hydrophobic lens, where you can see a lot of opacification that has happened in a hydrophobic IOL. And this is the left side picture, the central opacification in a hydrophobic IOL of an Indian IOL. And these are some of the pictures where there is a lot of pigment deposits happening in uveitic eyes. And here in the last picture, you can see there is pigment dispersion over the IOLs. So these are very common to happen in hydrophobic IOLs, and these things generally do not happen in a hydrophilic IOLs. So my indications for implanting a hydrophilic IOLs, I'm very particular that patients with retinal vascular disorders like diabetic retinopathy, vein occlusions or vasculitis, uveitic eyes, and also if in a situation where you have an extended rhexis, where the rhexis is extended, I generally implant a hydrophilic rather than a hydrophobic. And obviously any vitrectomized eyes, there is no point in implanting a hydrophobic IOL, I just implant a hydrophilic IOLs. So this is a case where I had a very hypermature cataract where I had an extended rhexis. So in such cases, I generally implant a hydrophilic IOL rather than a hydrophobic, because I don't want to expose the IOL to the uveal tissue. And obviously, once the rhexis is extended, there is no point in implanting hydrophobic IOL, because that's not going to prevent PCO anyways. So this is a case of, you can see there is a small silicon oil bubble in the anterior chamber. So this is a silicon oil filled eye undergoing a cataract surgery before the removal of the silicon oil. I generally do cataract before removing the silicon oil, because at the time of vitrectomy during silicon removal, I generally remove the posterior capsule also. So in such cases, I'm implanting a hydrophilic IOL, and at the time of silicon oil, I just remove the posterior capsule, so there is no question of developing any PCOS at all. So in such cases, you should be very careful that you don't decompress the eye, so because the oil starts coming out from the zonules into the anterior chamber. So Rayner has developed a lens with excellent intermediate distance vision and intermediate vision. It's an extended depth of focus lens. So it is called Ray 1 EMV lens with enhanced depth of focus. So it is, what the basic concept is, they have created a positive spherical aberration about 0.5 onto the central part of the lens, which creates a continuous range of vision from the intermediate 66 from 60 centimeters to the distance. So this is how the lens has been created. There is a central, positive asphericity, which gives you a good depth of focus, and there is a transition which gives you a good distance vision in these eyes. So this is the way the patient can have a good depth of focus from about 60 centimeters to distance. So I would call these lenses as super monofocals rather than telling them as an EDOF lens, because they don't give a real good near vision in these patients. So I would always call these as super monofocals. So you can, you can actually see these normal aspheric lenses actually give a 0.5 depth of focus, but here you can have almost a 1.5 depth of focus. So what the company actually says is, if you can actually, if you actually look at this chart, you can see that both the eyes are given same emmetropic correction. Then you will have something like this. From the 60 centimeters to distance, they have a good vision. They can also make one eye little myopic by 0.5. That gives you a continuous range of vision from almost near to distance. But I am not a big fan of giving a monocular vision. I try to, because you lose stereopsis in such cases. But a patient who does not have too much of demand about stereopsis, then maybe you can go for monovision with these lenses. So this is how emmetropic with enhanced monovision you can achieve. So Ray 1 is an extended range of vision. It gives superior intermediate vision, which offers 1.5 diopters of extended range of vision. It is a very forgiving lens because you have a range. Even if you miss your target a little, it is very much a forgiving lens. And it is not pupil dependent. So, there is no loss of contrast or loss of sensitivity. There is no glare or no halos because there are no rings associated in these lenses. It's a fully preloaded version. And believe me, the delivery system is very good. It's almost very smooth. I never had any problem of delivering these lenses. So this actually, all the hydrophilic lenses can be implanted from less than 2.2 mm incisions. So this is just a case. This is a myopic eye. A simple cataract surgery with NS2 grade. I generally use always an Uttarata forceps, and always my standard technique has been always been a 2.8 incision and direct chop. And I always use Dr. Mohan Rajan's chopper. That's my standard chopper for any case, which is about 1.5 mm. And I always make sure that I polish my anterior capsule in almost every case. So because of which I think when you make a smaller axis, that prevents capsular phimosis. That's very important in, especially if you're implanting these hydrophilic IOLs in pseudoexfoliation cases or retinitis pigmentosa cases where you tend to get a lot of capsular phimosis. So this is the lens on the first post-operative day. So it's well centered. The shine is, obviously the shine of the hydrophilic lens is much better than a hydrophobic IOLs. So this is one more case where it's a relatively smaller pupil. So this is the lens, the way it delivers. It's very smooth, it's very predictable, it's not temperature dependent. Sometimes when I implant hydrophobic IOLs, if it is a very cold atmosphere, then I ask my sisters to switch off the AC, air conditioning sometimes, because the hydrophobic lenses, they don't open well. But that is not the case with these hydrophilic IOLs. So this is a little modification that in a vitrectomized eyes, so this patient after finishing the phaco surgery, I actually use a 26 gauge needle. This is vitrectomized eyes with dispersed vitreous hemorrhage. So I just use a 26 gauge needle and remove the posterior capsule, aspirate the posterior capsule, and also remove the fluid, the blood fluid from the vitreous, just using a phaco aspiration. So from the side port, I use the irrigation, and I connect the aspiration to the 26 gauge needle and aspirate the blood. And you can see I have made up good posterior capsular opening with the needle itself. So this is also a different case. It's a vitrectomized eyes, but there's a lot of dispersed vitreous hemorrhage post vitrectomy. So in such cases, what I really do is I tend to make the posterior chamber and anterior chamber as a single chamber. So that is the basic principle what I do. So that is how we do it is you implant a hydrophilic IOL, remove the posterior capsule. Once you do that, the anterior and posterior chambers become a single chamber. So even if there's a dispersed vitreous hemorrhage, the RBCs just come into the anterior chamber and they get drained out from the trabecular meshwork. So that is, so in any vitrectomized eyes, my choice of lens is always a hydrophilic IOL, never a hydrophobic IOL, because I don't want to have any sticky posterior capsule. The parameters for phaco does not change if it's a vitrectomized or non-vitrectomized eyes, they remain the same. So I have implanted EMV lens, and I'm using a 23 gauge trocar, because standard vitrectomy probe comes as 23 in most of the phaco machines. So I have used the irrigation from the side port, and then you can see I have introduced the phaco vitrectomy probe, and you can see I have removed the posterior capsule also and drained all the blood from the vitreous cavity. Thank you. If there are any questions or any doubts about, because it is very much rather than a lot of belief that hydrophobic IOLs has to be the choice of lens, it is not the case. It has to be individualized as per the requirement of the patients. I think hydrophilic IOLs have a very good role in the routine practice. Any questions?
Very nice presentation. I agree with you that Rayner EMV is a very good lens, though it's a hydrophilic platform. But I tend to disagree with you that hydrophobic lenses, you can see a lot of pigment dispersion. You saw the eye.
Not in every case.
Yeah.
In a normal eye, I would say hydrophobic is the choice of lens. But in complicated eyes, in uveitic eyes, or pigment dispersion cases,
I don't think so.
I have,
by nature, hydrophobic material is more biocompatible. That is a basic.
No, sir. Hydrophobic are.
So hydrophilic lens can a good
UVL by say basically
can be as good as a hydrophobic lens, cannot be better than that.
No, hydrophobic IOLs are very good capsular biocompatible, sir. Hydrophilic are UVL biocompatible. There are two things biocompatibility. One is capsular, and the other second is UVL. Because of the water content, the hydrophilic IOLs are more UVL biocompatible, while the capsular biocompatibility is the best in hydrophobic IOLs. So that is the reason why, if you have a PCR and you implant a hydrophobic IOL in sulcus, you will see very, very bad glaucomas in such eyes. Never implant a single piece hydrophobic IOL in PCRs. Why do we not never
even single piece hydrophilic also you cannot implant in?
You can, sir. No. The only problem is they don't stay, because they don't stick. They don't stay. That is why we generally don't implant hydrophilic IOLs in sulcus.
The message I think we should give is that when you have a PCR, don't put a lens. If you want to put a lens in the sulcus, go for a three-piece.
Three-piece lens is the choice of lens.
Either a hydrophobic or a hydrophilic will be adding fuel to the flame. That's my opinion. But all other things are okay. Biocompatibility is okay, but biocompatibility can be either UVL or capsule. But I feel that even the new generation hydrophilic, the PCO is also not very much like what we used to see before. So PCO is not a very major issue, but I feel that hydrophilic lenses are very good. They are much cheaper than the hydrophobic lenses. But in a situation, in a particular situation, any situation for that matter, my go-to lens will be the hydrophobic lens. Of course, you are having some experience, you have shown that also. But I want to take this thing from the audience as well. Rishi, what's your go-to lens, hydrophobic or hydrophilic? Hydrophobic.
It depends.
Sir, it's a hydrophobic.
On a normal eye, I would say hydrophobic.
No, normal. It's not normal or abnormal. Yeah.
But in cases where you have lot of
you tell me.
exudations, like uveitis or vasculitis, that is where
See, the reason why we are all going for hydrophobic is that...
Extended rexes. I generally go for hydrophilic rather
Sandeep,
than... Sir.
the reason why we are going, because the hydrophobic has got a very long track record, very good track record, number one. Number two is, if you see all the opacifications, I have reported 26 cases of opacification of hydrophilic.
Of the hydrophilic I will.
Hydrophilic.
Yes, sir. But actually I have shown the pictures of opacification of hydrophobic I will.
That is not opacification.
Glistenings.
That is subsurface glistenings.
Glistening, sir.
That is the difference.
But that is, yes,
that
sir,
is
glistenings.
only with the particular hydrophobic, which is alcohol acrid soft, but now they have changed the platform also.
Now recently they have changed, sir. After so many millions of implantations.
But that is not opacification.
It's a glistening, sir.
That is the glistenings.
Yes, sir.
That is only with the particular acrid soft material.
And I have seen also with some Indian companies with upper Sony materials also.
You say the Technis and the Envista and all other lenses, they're all glistening free, and so many hydrophobic lenses are there available.
I just want to share that this kind of things can happen in hydrophobic, but it is unlikely in hydrophilic. Recent hydrophilic.
What is your take on that?
No, my go-to lens is
Calcification.
hydrophobic.
Yes, sir.
I don't use hydrophilic lenses.
I don't disagree, sir. I don't disagree. In my go-to lens in a normal eye, in a diseased eye, in uveitic eyes or vitrectomized eyes, there is no point.
No.
Why do you want to?
So you are telling. Okay.
Sir, pediatric, it depends on what kind of. Most of the times it is hydrophobic, sir. But if it is an uveitic pediatric eye, then I go with the hydrophilic.
What is biocompatibility? Because it induces less inflammation.
Yes. Yes.
So when there is already inflammation, uveitis, whatever you are telling, why you want to put a lens which incites more inflammation?
There is no thing as a UL compatibility and capsule compatibility.
It's a biocompatibility, that's it.
Biocompatibility.
I think, we believe in that, sir. So that's my, actually if you look at the literature, there are two components. Biocompatibility, there are two components.
How PCO happens? Again, it is a inflammation, fibrogenesis,
It's more.
So it's
sir,
basically
PCO, I don't think it's inflammation, sir. It's the growth of the epithelial cells. I don't think it's an inflammation. PCO is basically proliferation of the equatorial epithelial cells.
Why it happens with hydrophilic and not with hydrophobic?
Square it, sir. Because hydrophilic comes as 18% or 18 to 25% hydrophilic nature. The moment you put these lenses into the water, they swell up.
See, that's called the capsular index. Okay, wherein there is an addition, bioaddition between the capsule, the beyond the optic, both the anterior and the posterior capsule gets fused very fast in a hydrophobic lens. Tacky, yeah, because of that.
Right.
So it's called the capsular bend index. So it's very, very, very good in acrid soft material. The problem in hydrophilic, there is always a space there. There is a potential space between the capsule and the optic of the lens. So that's the reason for the migration of the epithelial cells from the equator across.
It does not stick well, and the square edge does not happen. These are two reasons for the PCOs in hydrophilics.
Yeah. Okay. Anyway, it's you have opened our eyes actually, because you opened.
I know, sir. This is very contradictory statements that I have made, because the industry does not really. It has been industry driven that hydrophobic has to be the goal lens, but I think it is also time for us to understand a little more. These are my thoughts. I just shared.
No. Just because I know it's an industry talk, I fully agree with you. Rainer is a fantastic lens.
Yes, sir.
Whether it's EMV or even the regular Rainer ones, we have used so many of them. They are very, very biocompatible. They are also very good lens. So, and many people are using Rainer on a regular basis. But to compare that and saying that it is better than hydrophobic, that is what...
I never said that, sir. I never said that. It's only for particular, situationally. It's only that is this thing. Thank you, sir.
Excellent.
Thank you, sir.
Now, Dr. Rishi is going to talk on sustained hydration MDPF. So, is there Siddharth Reddy, Yasmin Aziza?
Can I have the slides, please? So at the outset, I'd like to put a disclaimer that the slide deck was given to me by Alcon, and this is an industry-sponsored presentation, and we thank Alcon for their support for the conference. So the topic is preservative-free lubricants in the management of post-refractive surgery dry eye. And I think all of us who are doing dry eye, we know that probably the most common cause for our refractive surgery patients being unhappy is the dry eye. Okay, and probably even cataract surgery, I think that this holds true, that you will probably give them very good visual results, but they'll complain of some chuban or some irritation or some discomfort, which they call dry eye. So studies have shown that as much as 8 to 58% of the patients being planned for refractive surgery reportedly suffer from dry eye before you have done the refractive surgery. So if you look carefully, a lot of your patients who you are taking up for refractive surgery will already have dry eye. Simple things you can do to diagnose pre-existing dry eye. One of them is just to stain the cornea, stain the tears, and look for tear film breakup time. Normally, tear film breakup time of 25 seconds or more is pretty healthy, but anything less than 10, it's a red flag. And these patients will end up with some form of dry eye after your lasers, and they will trouble you. So if you do have that, please try and address that before you take them up for surgery. Otherwise, you will be prepared to have a post-refractive surgery dry eye. Okay, so almost 95% of all people after laser will have some dryness. By 1 week, this number comes to about 85%, and eventually by 1 month, it settles at around 50%. So it's a significant problem of post-refractive dry eye. And enough studies have shown that this is one of the most common causes of dissatisfaction after LASIK. 2 independent retrospective studies evaluating post-LASIK patient referrals to tertiary ophthalmologist care centers identify approximately 30% of patients post-LASIK with dry eye. So how does post-LASIK dry eye happen? It's many theories as to what causes it. Some people believe that the suction from either the microkeratome or the femtosecond laser suction causes damage to the goblet cells. One theory is that the nerve plexus, subepithelial basal nerve plexus, gets damaged either by the microkeratome cut or by means of the ablation of the stroma after the flap has been elevated, causing some sort of a neurotrophic keratopathy. There is an entity called line, LASIK-induced neuroepitheliopathy, where you see linear SPKs in patients after LASIK, and it's very typically seen in the flap area. Then because of change in the shape, you're flattening a curved cornea, and that also can result in an unstable tear film, and increased tear film breakup time can be attributable to that. So multiple things, reduced damage to the nerve plexus resulting in reduced sensitivity, and blink rate gets affected, and that can contribute to inflammation, and then a cycle of dry eye sets in. So there have been studies showing that SMILE may actually be better than LASIK, because in SMILE you're not really cutting so many nerves, you're going and dissecting a lenticule at a deeper plane, which is lower than the subepithelial basal nerve plexus. So at least in theory, SMILE is probably better than LASIK in patients who have pre-existing dry eye. So if you have a patient with dry eye and you have patient is suitable for both, it may be a good idea to tilt them towards a SMILE or even a surface ablation for that matter, because the ablation might be superficial to the subepithelial nerve plexus. So this was a confocal microscopy study of the images of patients pre-operative and post-operative after PRK, LASIK and SMILE 1 year after. So top 3 images are pre-operative, and bottom 3 you can see the SMILE looks as good as a virgin cornea, whereas LASIK looks the worst, the nerves, and PRK is somewhere in between. So changes in corneal curvature, how does it affect? It alters the friction between the cornea and the lid, unstable tear film resulting in dry eye. Suction can applied for the either microkeratome or femtosecond laser cut can damage goblet cells on the conjunctival surface, and there can also be corneal nerve disruption which alters the membrane associated mucin expression. So again, mucin can be deficient because of these two reasons, resulting in evaporative dry eye again. Okay, so you can see pre-operative and post-operative goblet cell density. There is definitely a significant reduction in the second image compared to the first. So what are the clinical manifestations of dry eye after corneal refractive surgery? Is sustained even up to 12 months. Vital staining of the cornea becomes normal, takes about 3 months to become normal after PRK. Smile 1 to 3 months, and LASIK it can take up to 6 to 12 months. Tear film breakup time post LASIK normalizes by about 6 to 12 months. Smile 3 to 6 months, and after PRK about 3 months. And corneal sensitivity recovers by about 12 months after LASIK, 3 to 6 months after smile, 3 to 12 months after PRK. And nerve morphology recovery may take 24 to 60 months after LASIK, and 12 months after smile, and 24 months after PRK. So in general, smile and PRK definitely superior to LASIK, and LASIK is definitely the worst of the lot. Okay, so again, how does one go about diagnosing various types of dry eye? And we use tests like Shermer's tear film breakup, meibography, staining, and questionnaires like the OSDI, etc., and try to categorize the dry eye into aqueous deficiency, evaporative, mixed type is usually the most common one. And neuropathic dry eye can be specific in patients with refractive surgery, and if the patient has already got an element of neuropathic, then better to avoid refractive surgery in these cases. They will complain of severe pain also after surgery, and they will trouble you. So neuropathic patients, basically you won't see anything, but they'll keep complaining of some symptoms, and all your signs will be normal, your tests will be normal. So these patients are likely to have more symptoms after you fiddle with those nerves. So with this background, Sustain has launched this new drop called the Sustain Hydration PF. PF stands for preservative free. It's a multi-dose vial and preservative free Sustain Hydration along with HP guar. So it gives you the advantage of HP guar along with sodium hyaluronate, and it also has got polyethylene glycol in the mix. So it has got 2 lubricants as well as HP guar, and that kind of gives a very good combination, and the icing on the cake is the preservative free. So the preservative free drops, are prone to contamination. So to prevent them from getting contamination, it has a unique drug delivery system called the Novelia bottle. We know that it's available from other companies in India. So now it's available in with Alcon in the Sustain Hydration preservative free formulation. It will be available shortly. I think they have plans of launching it very soon. And this is how it works using something called a pure flow technology. So intake of air into the dispenser takes place via a separate venting system through a silicon membrane called the pure flow technology, and the membrane's intermolecular distance is in nanometers, allowing passage of air through the membrane but completely preventing the passage of liquid or solid, including bacteria. So studies have shown that up to 1 month it stays microbe free. And this has been done by various challenges like the tip submersion challenge, air intake submersion challenge, and the microbial surface challenge. So like I said, the beauty of this molecule, Sustain Hydration, is it's a combination of HP guar along with sodium hyaluronate. Sodium hyaluronate we already know has a longer retention time on the ocular surface, and when you combine it with an element like HP guar, that gels the lubricant onto the surface of the eye and increases its retention on the cornea even further. And this has been demonstrated by various lab as well as clinical studies. This is one lab study in which they created an epithelial defect, and they've seen that the combination showed almost double the speed of corneal reepithelialization compared to just sodium hyaluronate alone. This is again another study showing the speed questionnaire scores being much better in patients who are getting a combination of HP guar along with sodium hyaluronate. So this was another study comparing two topical lubricants on the corneal surface, recovery and patient discomfort after PRK. And this had 68 patients, 34 within the study group which received this combination and 34 received CMC, and the various parameters were evaluated, and they found that the study group 97% were reepithelialized by 4 days compared to the control group at 85%. So it was definitely better in the study group compared to the control group which had only CMC. So this combination is definitely working better, and both were preservative free. So I think the thing which this study is, this presentation is not really touched upon is the preservative free. Any drop which needs to be dosed more than 3 or 4 times, if it has a preservative, the preservative itself can cause so much damage. Sometimes the treatment with the preservative is worse than the disease itself. So if you need to dose up to 4 days, any lubricant can be used. You don't need to use this. But if you want to use more than 4 times a day, then I would suggest always choose a milder preservative, and if possible, go for a preservative-free drop. So till now we were having a dearth of good preservative-free drops, especially from multinational companies. Now we have that option available thanks to this drop being launched by Alcon. And to conclude, 8 to 58% of patients being planned for refractive surgery suffer from pre-existing dry eye. 94.8% of patients have dry eye at 1 day, and this reduces to about 59% by a month after refractive surgery. Refractive surgery related corneal nerve damage is the main cause for dry eye, and its impact varies depending on the type of surgical procedure. Perioperative management of dry eye is needed for optimal outcomes after surgery. Management with preservative-free artificial tears are recommended. HA along with HP Goa based preservative-free artificial tears offers benefits of moisture retention, symptom relief and reepithelialization compared to plain HA based artificial tears alone. Thank you.
Yeah, thank you, Rishi. That was a very good presentation. Any questions?
I'm very happy with sustained hydration, and sustained complete I thought was better, but the problem is I think it contains that lipid
So you have to use it for patients who have evaporative dry eye.
Evaporative dry eye.
And those patients simply love it. In fact, I use a combination of that along with Restasis. Restasis also contains oil, castor oil base. So it works very well for my evaporative dry patients. And I think it's really been a boon for our patients, because evaporative dry eye is actually the most common form of dry eye. So I think...
What about the cysteine gel?
Cysteine gel is highest retention time, but causes some amount of blurring. So I reserve it for patients who have authentic dry eye, those who are really having very bad dry eye, but you can't dose it every hour like a preservative free. So I think a combination of this preservative free drop and using the gel 3 or 4 times a day is a good idea.
So cysteine hydration and
preservative
cysteine
free
gel.
Along with gel. I wouldn't use the regular cysteine hydration every hour because it has a polyquat preservative.
Yeah.
But this preservative free now that we have available, I think this is a great combination.
Very nice.
Thank you.
Dr. Mohan Rajan will speak on industry talk of Appasamy.
Yeah. Do you want the adapter? Sure, no? Is only one? Rishi, take one. That's yours, sir?
Yes, sir.
I don't want. If necessary, I will ask. Good evening, ladies and gentlemen. Let me thank TOS for this wonderful opportunity. And I'm going to talk to you on this, since it's a sponsored session by Appaswamy, I thought I'll talk about the Appaswamy technology and the Appaswamy IOLs in this particular session. So I'm using a Galaxy Leo mission, you saw that. I'm using a 3D, but that is not Appaswamy, the 3D RTO Zeiss system. So I use the 3D surgery now. So this is a patient who is almost a one-eyed patient. The other eye has got a macular hole, so 2/60 vision. This by fairly dense cataracts, almost quite intumescent cataract as well. So since they told me time was missing, I also didn't edit, so, but I will go through it very fast. The first incision I always put is the side port incision. And then I put in this particular case, because it's quite near total cataract, so I thought I'll just put the trypan blue, so that the capsular access becomes easy. So now I'm switching over to the microscope view, just to show you the Galaxy Leo mission. There is a beautiful mission. We'll talk about the mission. And so I just inject Cohevisc, which is a sodium alginate made again by Appaswamy. Whatever I'm using here is all Appaswamy. And this guard knife, and I go up on the cornea and then dip down, and you can see here, once I dip down, I have a fairly good long tunnel as well, not very long but not very short as well. And then I go ahead and do what is called the pinch the rhexis. Once I pinch the rhexis, I move it around with the capsular rhexis forceps, which is Suga Salgipukar's forceps, and then go around and conclude the tear from outside in, just to show you how to do a fairly round rhexis. It's possible consistently. Of course, we have the access to the femtocatalyst as well. So, just to show you that how to do a hydrodissection, going underneath and then depressing the nucleus back into the bag. Every time you go do the hydrodissection, you depress the nucleus back into the bag to prevent a capsular blowout or hydro rupture for that matter. Then I rotate the nucleus and see, and then this is a 15-degree tip, which is a Galaxy Leo mission. So I make a small trench there. So first I remove all the superficial cortex and epinucleus. The trench is for me to bury the phaco tip into the, so you can see this fairly dense cataract as well. And once I bury that into the thing, I'm using my chopper, which is again made by Appaswamy. It's available in 3 sizes, 1.5, 1.75 and 2 millimeter. 2 millimeters for black cataracts. This is a 1.75. The advantage of this chopper is a long and sharp chopper. It goes, and you can see here how I'm doing that. You can see how the chopper works like magic. So the most important thing is the vertical chop, the chopping right in front of the rhexis margin. You need to tilt the phaco probe slightly down and go into the body of the nucleus, and then chop right in front of the rhexis margin. The chopper is directed towards the optic nerve. Don't tilt the chopper, and try to see the posterior capsule through and through. Go all the way down. The advantage of this long sharp chopper is that, you see, with one stroke with very little lateral separation, you are able to open up the posterior nuclear plate, which is the main culprit in these very brown cataracts as well. So the posterior nuclear plate is the very toughest. I'm using a not very high vacuum, around 350 vacuum, and a flow rate of about 35. But you can see that it works like this is a peristaltic system, but works like a venturi. You can see how the nucleus is beautifully following. And same thing, you can see the chamber stability also is very good. And another advantage is the what you call the orbit cool technique, or the technology which is there, which is again part of the cold phaco technology. And this is the orbit cool technology which is there in the orbit handpiece, which is the lightest handpiece in the world. And we have to give it to Appasamy guys for consistently innovating and bringing it to us at a very, very reasonable low cost as well. You can see here, I'm just all the nucleus pieces just walk into the phaco probe. We don't have to chase. And this is again, I'm burying that phaco tip, creating a nice vacuum seal there, and then chopping, making very little separation. Chopping, this is a vertical chop. In horizontal chop, you go underneath the rexus, come from the equator. Vertical chop, you do it right in front of the rexus margin. And you just have to stay there. Once you chop the cataracts into smaller pieces, you just have to stay there, because the another important thing is the occlusion micropulse, which is a big feature in this machine, wherein on occlusion of the tip by the nucleus, the micropulse automatically starts, and you can go in the foot switch and you can alter the number of pulses, the phaco power. It is also got dual linear, like similar to the Stellaris. And you can see that no time the whole nucleus has come out, and this is just taking the epinucleus out. Sometimes you can have accidental hydrodelineation. Normally we don't do hydrodelineation, but sometimes the accidental hydrodelineation occurs, so the epinucleus has to be there. And this is just to show you the last piece of the nucleus also. I don't reduce the parameters throughout the surgery. It is the same parameters. You don't have to reduce the flow rate or the vacuum. Taking the long, seeing chamber stability is pretty good. When I come out of the eye is something which I learnt and I'm doing for quite some time. See how I'm, just a very simple tip. Take a cotton bud and press that wound when I come out. The advantage of this is that the chamber will not shallow. The nucleus, the PC will not come forward. I always use the coaxial curved irrigation aspiration. And one of the most important things in the coaxial irrigation is always to remove the subincisional cortex first when the bag is open. A technique which I have learned from Bobby Osher. So you can see here, I'm always staying under the rexus margin and going clockwise and then going anti-clockwise. And in that case, you'll be able to remove all the cortex. So when the bag is open, it is very easy to remove the subincisional cortex. But the curved coaxial, I don't find any difference. I don't want to put an additional incision on the right side, because too many incisions. Sometimes you have 1 millimeter incision on the side port and 2.4 millimeter in the main port. It becomes a little bigger. So just to show you how this is going on. And I always stay underneath the anterior rexus margin. Don't try to catch the posterior margin of the cortex, because you can catch the PC inadvertently. So again, capsule polishing to find out, to make sure that the epithelial cells are removed. I don't vigorously polish the anterior capsule, but I just do some polishing here and there. Again, when I come out of the eye, that cotton bud works very well, preventing the chamber from coming. In a case of posterior polar cataract or PCR, I inject visco through the side port before I come out of the eye. This is actually a fantastic lens which I have been using for almost more than 1.5 years now, almost 2 years if I'm right. And this is a Swiss phobe lens which is made by the Appasamy. Just like many other inventions from Appasamy or many other products, this is also a fantastic product. And this is a hydrophobic acrylic platform. And this hydrophobic acrylic, you can see there's undulation in the haptics as well, that gives you better stability. It has got a 360-degree square edge, it is similar to the high-ans lens. This is called it's not an EDOF lens. Please don't get confused between an EDOF lens and a monofocal plus lens. Sandeep was telling about super monofocal. This other name is the monofocal plus lens. It gives a little more because the cost is very, very less comparable to a monofocal lens. And the advantage of this lens is that there is no zones. There is what do you call the modification of the anterior surface of the central of the optic, wherein there is a positive spherical aberration, and this is followed by a negative spherical aberration, which actually induces a better depth of focus. So if you make these patients one eye, what I do is the first eye, I don't go for any dominant or non-dominant eye. The first eye I always make it the emmetropic for distance, and then the second eye I aim for about -0.5, not more than -0.5, because if you have -0.5, you land up in -0.75, it's okay. But if you have -0.75, -1, you land up in 1.25, the patient will kill you, because there will be a lot of this thing. So this is good enough because there is the inherent quality of this lens itself, which takes care of this particular problem. And just to show you this, how I remove the viscoelastic from behind the lens. If you are in bimanual, we can do this thing. I'm showing that, see this, this is a little fastidious about this. What I do is I hydrate the side port, I make it very tight. I make sure, unless the patient has got glaucoma or something like that, you can see how tight it is. And I always ask the patient whether he is able to see the light. Phacoemulsification using the Galaxy Leo Appasamy mission. This is a workhorse. This is the new kid on the block. This Galaxy Leo mission has got very, very unique features. The most important feature is this handpiece. This handpiece is called the orbit handpiece, and this orbit handpiece is the world's lightest phaco handpiece. You can actually... Yeah.
The advantage of this handpiece is that it's a 6-crystal handpiece and it's got delivery of power which is incredible. And also it's got a combination of puzzle and ellipse. And that is what is called the orbit technology, which is being patented by the Appasamy Associates. We have to give the credit to Appasamy for bringing such new technology and making this quality high-tech technology available to us, accessible and also affordable to one and all. This Galaxy Leo machine, just now you saw me demonstrating a very hard cataract phaco chop surgery or phacoemulsification surgery. The features of this Galaxy Leo machine is a peristatic machine. Another important feature is the orbit cool duty cycle. The orbit cool duty cycle is a mechanism of the cold phaco technology which is available in this machine. You can vary the on time, the off time, duty cycle. As you know, the duty cycle is the on plus As you go along in a push, you can alter the duty cycle, you can alter the micro pulses, you can alter the power. Everything can be done. And this is, in my opinion, one of the, what you call the wonder missions from Apasami Aerospace. We have to give a full 100% or 200% for this Apasami for making such a wonderful vision. I have been using this Galaxy View vision for the past so many years, and they come out with new upgradations, which is again a very important thing. Let me have a look, show you the foot switch as well. This foot switch is again a very important aspect, and I can see here this foot switch. There is also a dual linear foot switch. As you go along to the jump position, you can alter the duty cycle and so many other things as well. So this is, I think, a very important. It's like connecting a high configuration computer into the eye, and because of that, the sensors are so good, the system is so good, and the chamber stability is saw in this particular case, how the chamber was hit, distance, intermediate, and also to near not at 35 centimeters or 40 centimeters.
This is about the Swiss folk, yeah.
It works wonderfully well. What is the biggest advantage of the Swiss folk lens? This Swiss folk lens is wherein there is a modification of the anterior surface of the optic of the lens. The central area is becoming a little more positive spherical aberration as a negative spherical aberration, which takes care of the depth of focus, which is very, very necessary. So what I do is, I make one eye a little myopic.
Which I told already.
For micromonovision. The first eye I always aim for emetropia.
I just want to, since I have a few more minutes, I will show you. Because of this orbit cool technology which is available and the cold phaco, the corneas are very, very clear. In whenever I do the Galaxy Leo, irrespective of the even a brown cataract or a white cataract doesn't matter at all. Just to show you this, this lens I've been using. In fact, we have got publications as well on this. This is the in-focus lens. This is an extended depth of focus lens. This in-focus lens, as you know, is there is a central zone, supraphobe in-focus it's called. There is a central 1.4 millimeter zone, you can see that when I implant, and there is a special injector for that, and there is a central 1.4 millimeter, you can see that, which has got a 3.5 add. Beyond that there is a refractive aspheric. So it works wonderfully well. This is an extended depth of focus lens. The glare halos, we have had a large study, we published more than 400 eyes or something like that. Me and Nivian have published this and we have done, see, and you can see that Purkinje images 3 and 4 are getting focused in the center of that central zone, and very, very good lens, in-focus lens. Again, the cost is also very, very good. And this is a new invention, product from Appaswamy. You must have all seen the region, but there is a region T lens, which is a trifocal lens, recently been introduced just about a month back, and I've used a few lenses for the past 2-3 weeks I've been using. And it's a very short-term follow-up we have, but it's a beautiful lens actually, and it's a hydrophobic, it's a diffractive all the way, diffractive rings, just like the Acrylisa lens, and there is an anterior diffractive. Only thing is in Acrylisa it's a posterior diffractive. The anterior is diffractive zone, and this lens also stabilizes very well, and in the bag, and you can see again, one of the most important things is the third and fourth Purkinje images should come into the central area. Again, if you are in topical anesthesia, you can ask the patient to look into the light, and then you will know exactly. Always make sure that you remove the viscoelastic from behind, and if you are on bimanual, many of I think surgeons are now using hydro implantation of the lens also. But I'm since I don't have a bimanual, I don't use a bimanual. I'm not doing that as well. Just to show you that, see the centration of lens. This is a very short-term study. We have done only about 8 or 9 lenses till now, and all are bilateral implantation, and they are doing pretty well. But we need a long-term follow-up. Just to show you that the region T is also come in, and Appasamy is always continuously inventing and bringing about new technology, and they're not keeping quiet at all. Just like Ramesha and Jagdeep. So they are bringing up new technology, and all these new technology, everything makes sense for us, and it's not we cannot say it's all adding more importance to our practice, to a surgical practice, and we can actually extend our thing. And Swissfob is something which everybody can use. It's affordable, and it's got fantastic results. The biocompatibility. The reason why I asked Sandeep and I asked Chella also and Bharat also here is that all the companies are now shifting from hydrophilic to hydrophobic. What is the reason for that? Everybody was on hydrophilic, now is coming to hydrophobic. The reason why, because hydrophobic is definitely more biocompatible. There is no difference. Biocompatibility means, it doesn't mean it is uvea or capsule. It's biocompatibility means the lens which is there inside the eye produces the least amount of reaction to the neighboring tissues, whether it's capsule or uvea or cornea or whatever it is. So I think, again I told you, this hydration, if I have a doubt, if I am not able to make it tight, I always put a suture. Better to be safer than sorry, because I don't want that any wound leak post-operatively. Every time the patient blinks, if you keep it loose, every time the patient blinks, the the tear film tears will ingress into the anterior chamber, can have low-grade inflammation, infection, endophthalmitis. All these have been reported because of the poor wound. So the wound, I think, is a very, very important factor. And if you have a doubt, put a suture, nothing wrong. Just because you have told the patient it is sutureless, it doesn't mean that you should not put a suture. What is important, what is safer for the patient, you do it. You can always remove the suture after 2 weeks. So I make sure they are tight. I always ask the patient in topical anesthesia whether they are able to see the light. If they are not able to see the light, it means that your pressure has gone beyond the central retinal artery pressure. Then deflate the side port a little. Glaucoma patients don't do that. But glaucoma patients who got some problem in the optic nerve as well, so don't do that. But normally I keep the pressure around 30 millimeter, it works very well. Please understand, this corneal wounds, you have to structure the corneal wound. The corneal wounds are not as strong as the scleral wound. And the scleral wounds, we used to do scleral incisions long time back, but corneal wounds are not as strong. You have to make sure that you hydrate well. And too much of hydration also will be a problem. If you have a doubt, put a suture, nothing wrong. So, any questions from the audience or anybody in the panel? Huh? Yeah. Yeah, sure. You want to show your seat again? Photographer? Yeah. Oh, you mean the last one, okay. Yeah. I'll stop here.
Every alternate rings are at different. When you see from the side, you can see the alternate ring.
Yeah. I think mic is not working. You can come here. Yeah.
You can see the other rings are not visible. If you see here, they are at a different level. Each alternate rings are different level.
Yeah.
First, third, fifth, seventh. So one short set of rings are only for near, and the other set of ring is for intermediate. This is how they have created. Now, Hoa has done what? he has not only changed that, but the inferior portion of the ring is slightly broader than the superior portion to play with the optics.
Yeah.
This is how they have created this multiple type of
Geometric. Because when you see it under the, no problem, I think it's a good point. When you see it under the microscope, the geometric and geometric plus appear the same. When you see it, I don't find any difference at all. But if you probably this point is probably the micro level, you do not know exactly. But if you see it under the microscope, both appear the same. Yeah, geometric plus adnea. Yeah, but so I use a lot of geometric also, and I put mostly both eyes geometric only. But this region T is come, and because the region, the multifocal region of the original region multifocal of Appaswamy, I used quite a good number, and they went out of this thing. Now they have come out with a trifocal. But Swissphobe is the lens. I think we should all do it because it's really. There are many monofocal plus lenses available. The most thing is High-Ans was the first to come in, but subsequently all the companies have come out with the monofocal. The EMV Rayner we started discussing about is also a monofocal plus lens. All of them are playing. No zones are there, so future is going to be no zone lens. Like autofocus is going to become the future. Already is there, but it's going to. Because people don't want these ring lenses. The halos is something which we cannot predict which patient will get. That's a problem because all subjective and it's all neural adaptation. Sometimes the brain doesn't adapt at all. And if you make them a little myopic, the halos, glare, everything, photic phenomenon becomes a little more. So all these, I think the future is going towards the EDOF lenses without any zones.
Thank you, Dr. Mohan, for the good presentation.
Swissphobe? Swissphobe is around 6,000. 6,000, yeah, it's pretty good. High-Ans is 9,000. Yeah, 6,000.
I request Dr. Altaf Akbar to speak on Zeiss cataract workflow, efficiency without compromise.
Sir. Hello, sir. How are you, sir? Good evening, everyone. Outside, I'd like to thank TOSCON and the team Zeiss for inviting me. I'm Dr. Altaf. Now, you all, most of them are cataract surgeons here, and everybody must have encountered refractive surprises. I'm sure. Who is an happy patient at last? You all agree that the residual refractive power, anywhere the spherical equivalent below 0.5, you should be very satisfied with it. Anything above 1, the patients do start complaining, and how to avoid them. Now, you have the most important thing is the preoperative, then comes the intraoperative, then what would you do if you have a refractive surface postoperatively? I cannot cover all the topics completely because of the time restriction I have. Right. Now, how prevalent is astigmatism? In cataract patients, 47% of cataract patients have an astigmatism greater than 1 diopter, whereas 8 to 14% are between 1.5 to 2.5, and 2 to 7% are greater than 2.5. And this, in this era where patients are so demanding, this plays a vital role. It's just because if you don't do a proper pre-operative evaluation, back then, 10 years back, you did a good phacoemulsification. No matter what the residual refraction was, the patients were happy, but not anymore. So, if you don't consider the astigmatism pre-operatively, then you don't have good visual outcomes. Though you have done a good surgery, he is not a happy patient. Then, what exactly pre-operatively you look at? You look at the ocular surface, which is mostly neglected by most of us. If you do a proper slit lamp examination, then your biometry, your OCT if you have any doubts, and now for all the premium lenses, no matter what, we do a macular OCT for most of our patients. And what type of IOL you have to select, and of course the toric calculators. Now, when you're looking at the keratometry, all these play a major role. The dry eye, the epithelial membrane disease, use of contact lenses, RGP lenses, ask them to stop at least 1 month before, do a biometry, then later go for an ablation if you know that the patient is coming for cataract surgery. Of course, LVA is a big challenge. Now you know why post-refractive surgery, the calculation of keratometry is so difficult, because we are always, all the time doing keratometry for the anterior surface, neglecting the posterior surface because there are changes occurring in the posterior surface too. The axial length, the most importantly, when you're doing ultrasound biometry, ultrasound scan, you miss the centration. The fixation is not there. Even a slight change would differ in your final power calculation. That's why the fixation becomes of prime importance. Whereas staphylomas and silicone oils pose a different challenge altogether. Now, if you look at the studies, why do you get most of the surprises? The effective lens position. This is most important than where your lens exactly is placed, because all your calculations are based on that. The effective lens position and the axial length errors account for greater than 50% of your post-operative surfaces, post-operative refractive errors, whereas 10% are due to the faulty keratometry, because you are not considering the total K, you are not considering the posterior K too. Of course, intraoperative errors, I'll just go through them fast because this is a Zeiss session, I have to talk about them too. And intraoperatively, how do you manage? Right. How do you reduce refractive surprises? Of course, Zeiss have come up with a very good cataract workflow. Now you have the IOL master first here, then it goes into the like a server, and from then it is connected to your Callisto and back into your eyepieces. Then I'll talk briefly about each of them. Now, if you see the connectivity, what are the benefits of it? It has an anterior and axial topography too, but cannot be compared to your Sirius or your Pentacam, but gives a brief idea about it. Of course, you have the biometry is immaculate, it's very accurate. We have been using from past 3 years. Now, and next the connection to your Callisto, and finally you can evaluate your post-op. This is about the Zeiss IOL Master. We have experienced IOL Master, then we have come to IOL Master 500. Now we have come to the latest is the 700. It's the first swap-sort biometry, and the best part of it is they have a patented corneal to retinal scan. You know there is a slight pathology in the retina. Is it focusing on the foveal pit or not? And we had problems with IOL Master 500 where we could just, in hard cataracts it would never penetrate. But now, at least 99% of even all the cataracts were able to come out with a good axial length measurement. This is about that. Now, why is keratometry so accurate in that? It has 3 zones and it takes 18 telecentric points. Even if it's a slight defocus, you get a reasonably good K values. And of course, this is how it measures. It has got the 18 points as well as it gets swept source OCT with B scan, which estimates or measures the real-time posterior curvature of your cornea and come to the conclusion of the total K. The posterior curvature of the cornea plays a vital role in your refractive outcome. Now, the same thing is here, the total K and the topography. Now, there are various studies which indicate, why the measured posterior K is more important than your presumed posterior K. Right. Now, as I told you before, the cataract penetration rate up to 99%. So, but you need to have ultrasound machine too for those 1 to 10%, 1 to 5% of the patients. Now, this is the what I was talking about, the patented cornea to retina swap-sort OCT. Once you see This is the cornea, then you have the lens, you get the lens thickness, you get the central corneal thickness, antechamber depth, aqueous depth, or you get the axial depth as well as your lens thickness and axial length, all in a single print, and it hardly takes 45 seconds to get all the data. The macular check is what it is here. Suppose it also measures your central 1 millimeter. It gives a scan of your center 1 millimeter of your macula. Say you have a macula holes. It cannot be compared to your regular OCT, but still it gives a gross idea of how the macular, how healthy is your macula. Now, if the patient is not fixating well, then it doesn't show the foveal pit. So, and another important thing is the angle kappa. This angle kappa, what is it? It is represented as the offset between pupillary and the visual axis. And especially if you are going for a premium IOLs or multifocal IOLs, a large angle kappa greater than 0.6 will affect the IOL performance and can cause halos and glare. So, pre-operative evaluation and keen observation of these points will avoid later complications, especially in multifocals, who are all very demanding patients. Now that's a comparison. This is basically the workflow. The Zeiss Forum is a platform under which you have a Zeiss EQ workspace. Now you have an IOL master and you have a Cirrus OCT also. You can transfer all the data paperless into the forum or the EQ workplace. From there it is transferred again to your Callisto eye. Now the problem earlier we used to face is miscommunication between your optometrist, you have a printouts, all sorts of things we had, and we had confusion where, one, A scan was given to another patient. Now there's no chance of any confusion here where you have a proper workflow. So now what we do a OCT, we do a IOL master, directly it goes to your EQ workplace and directly into your Callisto eye and into your eyepiece. You yourself as a surgeon are responsible, so you verify before you operate. Of course, I'll talk about the Callisto eye, which altogether changes your toric placement. It also incorporates all these formulas. Okay, 5 minutes. Right. Now, this is the patient data, how it is transferred, the cataract, Zeiss IOL Master 700, you have a Zeiss EQ workplace, and of course this is the RTO, and we use a Lumira eye with the Callisto. Now this is the image you get in your IOL Master. It scans your, if I am right, the conjunctival vessels. I don't think it's an iris detection, it's the conjunctival vessels. And because of your torsional effect when in toric IOLs, this place, and we always, though we do a 2.4 mm incision, which theoretically or practically is astigmatically neutral, we always try to give incision if possible in the steeper axis. And this also, the Callisto eye has a special feature where you can, know your size of your axis too. Now this is the Callisto eye system. It saves a lot of time. Manually when you're marking your axis, altogether you have to take it in your hand twice or thrice to exactly know how you're placing your toric IOL. But if you have a Callisto eye, certainly it is done in a minute or so. And of course, the post-operative refractive surfaces, certainly if the astigmatism of his, sorry, this is about the toric IOL. Okay, the post-operatively you have surface, what do? The first thing you do is medical management. What is medical management? Counseling the patient according to me. If he accepts, he's happy, fine, leave him. Or else, if you have a greater than 2 diopters, we always think of exchanging the IOL. Probably if it is less than 2, in some cases, we always advise them to undergo PRK. They do excellently well. Even we have tried in some multifocal lenses where there were residual refraction, we have done PRK for those patients. If the multifocals are causing glare, most of us must have experienced this, and the high volume surgeons must have already, must have even exchanged the lenses. At least wait for 3 to 4 months. Patient is not happy. Better exchange the lens with just a monofocal lens. And if I have a little time, I can show you one flax. I think I have another 3 minutes left, sir. Yeah. Okay. This is already a femto-assisted capsulotomy is already done. Now this is probably a grade 2 to 3 cataract. I just wanted to show the axis. The axis is showing up to 180. You see how much toricity is there in this case. You can see that normally if you think that we are doing we are giving a 180 incision, it is not 180 actually. If you see this, so oblique actually, 180 axis is so oblique. Right, once we finish with the, most of the times in our machine, we use a catalyst machine. It's a free floating rhexis because we wait at least for 5 to 6 minutes post femto procedure and take up for cataract surgery. Then, okay, I'll just go ahead. I have just a minute to go. Then we finish with the cataract part of it. Now just left over with the cortex. I'll go ahead with the cortex, and I use bimanual. As Dr. Mohan Rajan sir has said, coaxial is very difficult for me. I was never able to adjust to that. Simply iris starts prolapsing. That's a technique I have to learn from you, sir. And another thing is, you're using a coaxial, people think you're a very old surgeon. Older technique. So I'm sticking on to bimanual. Right. Now this is the Callisto markings where you get, fortunately for me in this case it is 178 degrees. So this, the lens I'm using is, I think is a Clarion toric, what I'm using. And with the assistance of your Callisto eye, it's so easy in this. You don't need any marks. You don't have to, depend on somebody else, take him to slit lamp. Sometimes, the patient is lying on the table and suddenly you think that they've now marked the 180-90 axis. Then you send him back to the slit lamp and mark him. This is very hassle-free, and I try to do all my implantations with hydro implantation, because I don't want any visco there behind the IOL, and I don't have to waste much time. That is one advantage of using a bimanual. You can do a hydro insertion of the IOL. Then because if it is too, I can manipulate it with my aspiration. Another important thing in toric IOLs is, before you come out with the irrigation, try to hydrate your other wounds at least, because slight shallowing of the chamber can decenter your toric IOL. And don't overinflate your chamber, because you don't want to stretch the back too much. There might be some rotation of the toricity, and all my post-ops I make them sleep for at least, lie down, for at least half an hour, and then send them back. I think my time is done. So, and the final slide is that what is the benefit at a glance? You have got a beautiful central topography, you have got a total K including your anterior and posterior, you have got a cornea to the retina scan, it has a perfect fixation, and you have all the formulas you want. You want for a high myope, you want for a post laser vision correction cases, and the cataract penetration is up to 99%. And if you're using a Callisto eye, the results are amazing and saves a lot of time in your toric IOLs. Thank you for the patience.
So I will like to invite Mohan Rajan sir to take the certificate.
Very nice presentation, Akbar, and I fully agree with you that the Zeiss IOL Master is a game changer in my opinion, 700, because it gives all the information from the front to the back, and one of the most important thing is you make sure that your optometrist is well trained and because slight tilt of the eye like this itself can produce a cylindrical power, and you'll think it's because sometimes, you know, I compare many times, not sometimes, I compare the IOL Master 700 with my lens star. The lens star will show only 0.3, IOL Master 700 will show 1.1 or 1.2. Then again I repeat it. When I repeat it, it comes to normal thing. So that is one thing. Second thing is, before dilatation, before applying any drop, do the callisto, IOL Master, because once you apply a dilatation drop, the limbal vessel gets blanched and you will not be able to get the callisto image. So this is one thing which I have learned over a period of time. Just as soon as you see the patient, probably you can, don't touch the eye at all, don't put any paracane or anything, because the keratometry can get altered, you know that. So once you see the patient on slit lamp, you can probably do NCT. Even NCT they say alters the corneal surface. But you do NCT, then immediately send the patient to the adjacent room where the IOL Master 700 is there. First we take the IOL Master 700 images, then we dilate the patient and do the OCT and all other things. So this is again very important, because otherwise you will not get callisto for all these patients.
We totally agree with you, sir. Yes. Sorry for interruption. And we learned the hard way. As you said, we had one case where, you know, the optometrist had done, obviously most of the scans are done by optometrist, and we had a cylindrical of 2.5 and we implanted the toric, right, and we had not compared the other eye. Other eye had showed no toricity at all, no cylindrical power. That's where we should have had slight suspicion. We didn't do it, we implanted it, and then we had to face everything.
Absolutely.
So now what we do is, if there is any slight disparity, we ask another optometrist to do that, or we put him onto Sirius and do a corneal topography, and it also gives you the anterior and the posterior. We at least compare those with your IOL Master readings.
No, unless they have a squint or something like that. We don't do that.
Sir, the fixation point anyway you know, but not the corneal problem. See, the fixation anyway, it's going to hit the foveal pit, and even if there's a slight tilt in the lens also, you can know. But when there's a rotation like what sir said,
like
that is where it.
Suppose the patient is like this instead of coaxial.
Yes.
If the patient is, sometimes their forehead will not come into contact fully on this thing, no? So patient is, the optometrist may not find out that. These are all, over a period of time, we have burnt our fingers. And posterior polar cataract, it's a beautiful tool, because you know exactly what is the status of the posterior capsule. Exactly. There's no other mechanism. Whatever AS OCT use, you'll not be able to see reach the posterior capsule. But if you see do the IOL Master 700, you'll know exactly whether the posterior capsule is breached or some opacities will be there in the anterior vitreous. So whether any pre-existing dehiscence is there or not.
And even to diagnose it also, basically.
Yeah.
You know where exactly it is. You know, sometimes slit lamp.
Bharat,
whatever.
you would like to say something?
No.
Yeah. Thank you.
Thank you, Altaf.
I like to request Mohan Rajan sir to take the certificate. Appreciation. I request Dr. Rupak Reddy sir to take the certificate. I request Dr. Altaf sir to come to the stage. I request Dr. Rishi Swarup sir to come on stage. I request Dr. Sandeep Reddy sir to come on to the stage.
presented a PPT here. So there is a Zoom so they are sharing the
Okay. Acha hai. And what about when Dr. Payman comes on board?
Sorry?
Oh, दूसरा आदमी है ना? He's speaking from America.
Okay, so I'll just confirm with them, my team. So they know about that, sir.
Okay.
Yeah, sure.
So who knows?
Yeah, I'll call her.
I don't want any glitches.
Yeah, sure.
So because we got only 1 hour, I'm going to speak for 15 minutes exactly. And then I'm going to introduce Dr. Payman. And he's going to be on Zoom. And so as soon as I'm done, he's going to start talking. So you should make it seamless. You're assembly, right? You adapter? No.
Bro? Bro?
Zoom is ready. So how do you project my presentation on there?
Your presentation, right? Sir का presentation डालो.
Perfect. So how do you see when Dr. Payman joins?
When sir will join us, I can see their presentation.
Yeah, I know that. But how do I know that he joined? There's another box that opens up.
I can know from
You know.
Yeah, I will know.
Okay. So let's look out for, let's get out of, we can leave it like this. Okay?
I can know because I have the access. So I can, whenever he join, I can know the join.
So he's supposed to join in the next 5 minutes. I told him to join, ours is going to start at 6 o'clock, right? So the Zoom starts, I told him 30 minutes before. So in the next 10 minutes or something, he's going to join. So he's kind of old and he cannot hear. So he speaks with kind of low voice. I'm just telling you. So last night, you weren't there, right?
I was there.
You was there. Okay. So we went through, I think he knows how to modulate himself and etc., all those things, but we need to help him.
Yes.
So sometimes he may have problems with bringing his thing, so I'll try and cover it up. Now, as my talk is ending, is there some way you can bring up his, you cannot do that, right?
Sir, what?
As my talk is ending,
Automatic.
it will automatically come. Okay. So he took down the Zoom right now, right? So I'm going to close this, and at the time, all I need to do is to open this, and it should show up. I just want to warn you, I think I have a full battery here. Do you have the adapter that you have to give me a copy of the just in case? Always put in, yeah, you fully charged. But I think there should be enough power, just in case you run out of it. Over room, they had a same thing with the round. No, it's all set up. It's all set up. Don't go over.
అన్నీ ఆమెకి ఎన్నే కావాలి, నువ్వు చెప్పొద్దు అట్లా. ఈ కేబుల్ ఎందుకు పంపించావు అంటున్నాను. నేనేమంటే అట్లుంది పరిస్థితి. కేబుల్ ఉండదు, ఆ కేబుల్ मेरा नाम बोलो मेरा. हाँ इसमें हाँ किसमें भी होता चार्जिंग लगा. पूछो पासवर्ड पूछो. రైట్ అవుతుంది. అవరా సార్. ఫుల్ ఛార్జింగ్ కనెక్ట్ అయితే సిగ్నల్ ఎందుకన్నా ఫీల్ అవుతుంది మళ్ళీ అంత ఛార్జింగ్ పెట్టుకోండి. బ్రో స్నేహల్ బ్రో స్క్రీన్ టైం పెట్టినట్టు డిస్ప్లే కనెక్ట్ చేస్తాను. కనెక్ట్ ఏం లేదు, కనెక్ట్ అట్లా బ్లింక్ అవుతుంది. సిగ్నల్ నో సిగ్నల్ అన్నట్టు. మనకు ల్యాప్టాప్లో ఇంటర్నెట్ కానీ వస్తుంటే ఎట్లా వస్తుంది? అట్లా బ్లింక్ అవుతుంది కనెక్ట్ it's charging.
So when Dr. Payman joins, please let me know.
this disappeared. And I see.
Goam, can you hear me?
I can hear you. How about you?
Yeah, we can hear you loud and clear. And
know if I can actually open my file for you to put it down on the screen, but this is my file now.
yeah.
Let me get this.
So look for share the file on the bottom.
I'm going to put it in the bottom if I can. Okay. Okay.
You want to guide him through this?
Yeah. What? Share a screen or not?
No, we don't see your screen.
Okay.
You got to, on the lower half in the middle, you'll see the green icon that says share file. Share screen. Share screen.
So there is a green color ka button. There is a green button in the down that
So-
says share.
Share screen. Column, look for the green icon in the lower half of your screen. Stay within the zoom.
It's starting. I can see that here. Screen. That's your screen.
Yes.
And now you have to get my screen. Share
Okay,
my screen.
yeah. Reduce this screen.
No, sir. Sir, go down.
No, go down and look on the PowerPoint. Click on the red icon, PowerPoint, which says P. All the way down, and to the left, to the left. Okay, keep going, to the left. No, the other side, the other left, or the right. Okay, there. No, the next one. Golem, no, not that one, the other one. Yeah, there you go. That's it. Click on that.
It's, I got it. Okay.
Yes.
Now I have to remove this, I guess.
So, go down one more time.
Go down, sir.
So Golem, again,
Volume.
go down on your, go down on the screen.
There is a volume, sir. Right, sir, right. Go down, sir, right. Right, sir, right.
Okay, so you can click on it again and it will disappear. There you go. That's it. So in about 15 minutes, I'll introduce you. At that time, bring it up.
It's not ready yet, but it is here. Hopefully we can do that.
No, go back again to the bottom. You should see you should see the same icons all over again. The zoom, share, screen.
Can you see that now?
No.
You don't see that?
I don't see your screen.
All right. Share. That is say share. How about now?
Now we see it. There you go. That's it. So once I'm done with my talk, and then I'll do a brief introduction of you, not that you need an introduction, and then you do exactly what you did just now to bring up your file.
Now it is here. Hopefully.
Yeah, I know. We'll, at that time, we'll show you. Right now.
He's only half asleep, but okay. Your screen is better than mine.
I can help with doctor, right, for doing that? Yes, sir.
No, he's not confused. Right now, he's got it. Full screen, we'll do it at that time.
So he's aware of that?
He's aware of it. No, at that time, you show him the full screen.
Now if you can let him know, that's fine. Let him be on the full screen, right?
Well, last time we did full screen, you need to find the icon again, give a call. So let it be like this. When the time comes, all he needs to do is either go to the slideshow or press that other button and he'll be in full screen. Yeah. Yes. Okay.
Function FI shortcut full screen.
So what you're suggesting is that you can superimpose my presentation on top of it. That's what I asked.
That's it. So let him go on the
Stuff like that.
Yes.
Okay, I will ask him to enlarge his screen.
Yeah, right away. Yeah.
Right away, right now, and he'll be ready.
Yes.
And then you flip the screen to mine, and then once I'm done, you flip it.
Yes. We can add the spotlight.
All right. Yeah. He has to come back.
Yeah, he has to come back.
Yeah, we'll wait. So Golem, what's going to happen is this. They can flip the screen from my screen to your screen, so you don't need to do anything else. Just leave your presentation exactly like that. As soon as I'm done, our techie people here are going to flip the screen from my screen to your screen.
You want me to bring my...
Just leave it like that for now. Leave it exactly like that for now.
Okay.
Don't do anything. So as soon as I am done with the presentation, our people will change from my screen to this screen of yours. So that way there's less confusion.
All right, sure.
You doing well? I want to thank you for waking up early in the morning, taking the time to
Well, that's once in a lifetime. It's not going to be true.
So I think it's almost 6 o'clock, and we're going to go ahead and start the Ananda Institute sponsored program. I want to first of all thank everyone for coming here and all those people who are watching this show on YouTube. Welcome to Anandai Institute sponsored program as part of the TOS or Telangana Ophthalmology Society. So Golam, for your information, Telangana is a pretty large and rich state in the southern part of India. And the capital city, as we discussed last night, is Hyderabad, which is where this meeting is being conducted. And TOS leadership is right in front of me. They are, fortunately for us, and they all want to hear you, and they gave us permission to go ahead and host this session. So thank you, TOS. Those are my financial patterns, whatever it is, but nothing that I'm going to say has any effect on this. So on behalf of Ananda Institute, I want to welcome all of you to 14 years of Anandai in the state of Telangana. And welcome to our 14th annual Foundation Day celebrations, which is being sponsored or in one way being part of the Telangana Ophthalmology Society. And a big thanks to our sponsors, Intas and Cipla Pharma. Without pharmaceutical industry support nowadays, we can't host these kind of meetings, large-scale meetings. So today, what I'm going to do is to cover surgical glaucoma timeline briefly for the next 15 minutes, followed by my introduction to Dr. Golam Payman, who's online. He's waiting for my talk to be finished, and then I'm going to officially introduce you to our visiting professor for today, Dr. Payman. And then Dr. Payman is going to take you through his multiple inventions and the thought process that led him to do his innovative work throughout his career. So here is your glaucoma timeline. We started off with the iridectomy actually in 1850s all the way to 2020, where MIGS has become the main theme. And you heard many presentations today. So the original inventor in glaucoma in my mind is this guy here, Albert von Grafe, who invented his famous graphene knife. Many of you may not have used it, except for old people like me. As a medical student, I attended eye camps. I used the von Grafe blade to do the intracapsular cataract surgeries. That's one of the ways that I got myself interested in ophthalmology. So a lot of people in Europe came to know about von Grafe, and they all used to track him, including those patients with absolute end-stage glaucoma, with severe headaches and stuff like that. And so von Grafe famously put his knife into the eye and unknowingly created an iridotomy. And that resolved the headache in some patients, and in some patients it did not. What he didn't know, and he had to wait for another 60 years to know, is that glaucoma is of two kinds, open angle and closed angle. Those with acute attack of glaucoma, he was able to help with these iridotomies. Those with end-stage glaucomas from other reasons, with the high pressures, they did not respond. But in the recorded history, the first surgical treatment ever described to our knowledge is von Grafe's iridotomy. So thank you to him. Trabeculectomy is an age-old procedure, as you all know. Came out in 1960s, modified it by Kane in England. And as you all know, it directs the aqueous into the subconjunctival space. Subconjunctival fibrosis is what leads to its failure over a period of time. But a well-done trabeculectomy is always a pleasure to watch. I know a lot of people are giving up on trabeculectomy, which I think personally is a mistake, because there are quite a few patients who deserve trabeculectomy to achieve the kind of target pressure that we need in these patients. And in around 2000, the express mini shunt was introduced into the United States, where the initial statement was lift the conjunctiva, stick the express into the anterior chamber, and close the conjunctiva. A lot of those patients ended up with complications, including choroidal effusions, hemorrhage, and exposure and erosions. And we wrote one of the first papers when I was there. Dr. Payman was also one of my co-faculty at that time. He doesn't know this, but he was a mentor because I read his old books, and that was a great pleasure to have him as a co-faculty at that time. So anyway, in any case, based on our paper, they modified the surgical technique and converted that into a mini trap kind of a deal where they would put the express under the flap, and the success rate is about the same as a trabeculectomy, but at $700 more expensive glorified trabeculectomy, if you like. How about Zen gel stent? I don't know if it is available in the United States. This was introduced in 2016 in the United States. This is beautiful technology. Literally in 3 minutes you can do the surgery. Initially it was introduced as ab interno and later on converted into ab externo technique. And you can see this is unedited video of how to insert the Zen. Essentially this is a microtubule 43 microns in a diameter that diverts the aqueous out into subconjunctival space. And the big problem anytime we do any subconjunctival diversion is fibrosis. So all it takes to cover a 43 micron hole is what? A couple of fibroblasts. So a lot of these Zens do fail, and so extensive use of mitomycin needling and all of these problems are there. Watch this ab externo technique, which is so cute. Real time, unedited video. All you do is this. And name a glaucoma surgery that is as quick as this. You go in and then inject it into the antechamber, and 1/3 of the device goes into the antechamber, and 2/3 stays under the subconjunctiva, and then you inject some mitomycin around it, and you're done. Pretty much. Great. But post-op management is the key as in every glaucoma surgery, and the problem with this is exactly that. I did a lot of Zens back in the day, and then I gave up. And the reason why is this high failure rate. At exactly 1 month, a lot of these attracted fibroblasts and fibrosis around that opening of the Zen, and a lot of these started failing, and this